evening, ladies and gentlemen. We had 3 exciting days and welcome to day 4. As all of us know, it's an update in lymphoma. This is Lymphoma Month, which includes the best of 16th ICML International Conference on Malignant Lymphoma, Lugano. We are extremely grateful to our program director, Professor Dr. M.B. Agrawal, sir, who is president of Mumbai Hematology Group. And this group, under his able leadership, has been working tirelessly and have produced more than 200 plus webinars post-COVID time. No wonder, sir, you have been conferred the best of the accolades. One such one is Inspiring Hematologist of India by Economics Times. Thank you, sir, for enriching us. Over to you.
Thank you, Dr. Manoj, for those kind words. Good evening, friends. As was mentioned by Dr. Manoj, this is an update in lymphoma during the Lymphoma Month. It includes the best of the 16th ICML, which was held in Lugano a couple of months ago. We began on Monday 13th and will be ending on Sunday 19th, every day from 5:45 p.m. to beyond 9 o'clock. 3 best of the lectures by best of the international faculty presenting their lifetime work. And I think all of us in India and around are blessed by their acceptance to participate and deliver their lifetime work to educate us. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Mice Ideas. I thank Dr. Manoj Kumar and his team from INTAS, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our very, very important international guest speakers, and our today's chief guest, Dr. Hemant Malhotra from Jaipur, our discussants who are eminent hematologists or medical oncologists, and of course, all of you participants who are extremely important component of the success of these webinars for sparing your evenings and getting glued in. Day 4, Thursday, 16th September. And the discussants today include, from Mumbai, we have Dr. Subhaprakash Sanyal from Fortis Hospital. He is also treasurer of Mumbai Hematology Group. Dr. Sandeep Nemani from Usha Hematology Center, Sangli, and Shri Siddhivinayak Ganpati Cancer Hospital, Miraj. Dr. Shweta Lankan from Avinash Cancer Clinic, Pune. Dr. Amit Khurana, consultant hematologist and transplanter from Surat. Dr. Mahadeva Swami BC from Manipal Hospital, Goa. Dr. Nidhi Jain from Zadas Hospitals, Ahmedabad. Dr. Aishwarya Raj from Gujarat Cancer Research Institute, Ahmedabad. Dr. Abhishek Kakru from Vedant Institute of Medical Sciences, Ahmedabad. Dr. Gunjan Prasad from Apollo Hospital, Kolkata. And Dr. Isha Kaul from JP Hospital, Noida, UP. And now it's my privilege to introduce my friend and the chief guest of the day, Dr. Hemant Malhotra. Who does not know Dr. Hemant Malhotra? Even if you have something to do with hematology or medical oncology, he is an icon in front of you. He is Director Oncology Services at Shriram Cancer and Super Speciality Center, Jaipur. He is Professor and Head Department of Medical Oncology at Mahatma Gandhi Medical College Hospital, Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. President, Carcinogenesis Foundation, India. Immediate past President of Indian Society of Medical and Pediatric Oncology. Vice President, Immuno-Oncology Society of India. Vice President, Teen and Young Adult Cancer Foundation. Member, Scientific Advisory Committee of International CML Foundation. It's published over 200 peer-reviewed research articles in various reputed international and national journals. And of course, besides that, he has written chapters and chapters in various books. He holds important positions in various international and national society and organizations. He is a principal investigator for many path-breaking international and national clinical trials. He has been on the Data Safety and Monitoring Board for various oncology molecules. He has been the President Secretary of important national oncology societies. We proudly witnessed his selection as a faculty in the education program of ASH 2019, where he delivered the lecture on meeting the needs of CML patients in resource-poor countries in the section Patients, Borders, Money and Missions, a global perspective of CML. Dr. Hemant Malhotra, we are blessed by your presence. Kindly inaugurate today's webinar and give us your words of wisdom. Thank you so much.
Thank you very much, sir, for those very, very kind words. I don't think I deserve those, but many, many thanks. So, ladies and gentlemen, welcome to this day 4 of the lymphoma update organized by the Mumbai Hematology Group and its president, Dr. M.B. Agarwal. You know, I am not a fan of Dr. Agarwal. I am his air conditioner. I've known him for the past 30-35 years. You know, every time I interact with him, either virtually or in person, I am enriched as a person and I am enriched as a specialist. He is one of the best hematologists of our country and certainly one of the top educators which the field of hematology has seen. For this 3-minute address which I am giving you and welcoming you to this webinar, day 4 of the lymphoma update, he emailed me 3 months in advance. He blocked my date 3 months in advance. I do a few webinars myself. I give my speakers about 3 days advance, and Dr. Agarwal has the foresight and the planning expertise to do this 2 or 3 months in advance. So really, truly hats off to you and the mission which you are doing for us. So yesterday was World Lymphoma Awareness Day, and a day in which every medical oncologist and hematologist would like to convince the patients, the caregivers, the students that lymphoma is indeed a curable malignancy. So lymphoma is not the simple disease like non-Hodgkin's lymphoma and Hodgkin's lymphoma, which it was some 30 odd years when I stepped into oncology and I finished my training from Tata Hospital. It has become several different diseases. Hodgkin's disease itself has several different components and diseases. Non-Hodgkin's lymphoma is even more complicated. So today it is extremely important for us to know what advances have taken place in the field and what is the current treatment of this disease, what is the current approach to the patients with this disease, what workup you need to do, what prognostic factors you need to assess, and according to those prognostic factors, what is the best first-line treatment you need to give your patient. If the patient is unfortunate enough to have a recurrence or relapse, then you also need to know the best second-line treatment and know the best third-line treatment also. So under this banner of lymphoma updates, we are going to learn about the state-of-art treatment of this disease, this eminently curable disease. So you've already witnessed 3 days of lymphoma updates, top of the line, state-of-the-art information about lymphoma, and get ready to witness day 4. And I'm 100% sure that none of us is going to be disappointed with the quality of the academics, and each of us is going to be much wiser in the next 3 hours and much more enriched in lymphoma knowledge so that we can offer the best possible treatment to our patients. So it's my indeed pleasure and privilege and honor to kickstart this day 4 of the lymphoma update and enjoy the meeting. And thank you very much, Dr. Agarwal, for this opportunity. Proceedings back to you. So thank you again, sir.
Thank you, Professor Hemant Malhotra, for those kind words and inaugurating today's webinar. And may I have the screen to introduce our first guest speaker for the day, Dr. Stephen Ensel. He is already logged in. Just to introduce him, everyone knows him. He's going to He's professor and consultant, Division of Hematology, Department of Internal Medicine at Mayo Clinic, Rochester, Minnesota. And he's going to speak to us today on immunotherapy for lymphoma. Over to Dr. Stephen Hensel.
Well, thank you very much. It's really a delight to be part of this meeting, and thank you so much for inviting me. So I'm going to go ahead and share my screen and just make sure you can see my slides. Those slides okay?
Yes, sir.
All right, so goal today is to talk about immunotherapy for lymphoma. And as we go through this, I just need to start off by disclosing that the institution I work for does receive funding from a variety of different companies, and I will talk about some of their agents as part of our discussion about ways in which we can change the immune environment in lymphoma. So my goal in the next 45 minutes is to touch on a number of different topics. And I'd love to have you as the participants in this meeting just be thinking along with me about this. So the first thing I think we need to start off with, if we're talking about the immunotherapy of lymphoma, and particularly we're focusing on T cells, although we'll touch a little bit later on macrophages. If we're thinking about T cells, the key thing we have to ask ourselves, what are we striving for? What is our goal? What is the thing we want to see happen? So you're going to see me start off talking about what exactly is an effective T cell mediated immune response. We need to know what we're shooting for so we can judge what we're doing against really the objective of an effective anti-tumor immune response. The second thing I wanted to do is to highlight the fact that there are many immune deficiencies in lymphoma. And we're really going to highlight 4 of them, although there are more. But then the goal would be to talk about strategies that exist, that are in development, that are currently in use, that overcome those deficiencies in the immune response. And along the way, I'd like to sprinkle in some kind of complicating factors and limitations that we might have in what we know, just to keep us humble, to help us to realize that we haven't worked it all out yet, and there's clearly always additional work to do. So I'd like to start off with what constitutes an effective T-cell immune response. So shown on the top of the panel here is a CD4 or CD8 cell interacting with either an antigen-presenting cell or a lymphoma cell. And I think what's important to see is right in the middle of your image here is an MHC molecule, MHC class 1 or 2, that is presenting tumor-associated antigens, this little red dot that you can see, that is recognized by the T-cell receptor. So that, as you might remember from your days of biology or immunology at med school, is the first activating signal that happens. The issue, however, is that if that's all that happens, that would actually make your T-cell anergic and not allow it to actually do anything useful. There has to be a second message, and that second activating message typically comes through CD28 or 3, sometimes C, then arouse those cells to proliferate. Your immune system is trying to do inhibitory signal axis, but that is again one. So rather than receiving an activating signal, PD1 signaling can inhibit the cell. CTLA4 is another one, and all of these over here, TIGIT, TIM3, LAG3, are all these kinds of inhibitory signals. I think it's important to know not only that you can activate the cell, but those cells need to be persistent and need to actually remain around with immunological memory. So that's shown on this slide. This really just highlights what I said, but just shows you kind of the natural progression of the immune response. You can see on the left here the presentation, antigens presented in the context of MHC, recognized by T effector cells. Here you can see that synapse that we just spoke about, MHC TCR providing the first signal, and then B7 ligands, CD80, 86 through 28, activating the cell. The cells then will become, effector cells, lyse, as you can see here, the tumor cells. Important though that they don't just do it and be done, but they continue to activate and continue to target the tumor and persist while there are still malignant cells around. And then something that is probably the holy grail, we don't know that this really happens in cancer, would be nice if it did, is that there is immunological memory generated, meaning you've got T cells that stick around and would recognize the tumor and tumor antigens if they showed up again. So the importance of showing this is what we're trying to do. This is what your body does when it's exposed to a virus like COVID-19. This is what your body should be doing when it's exposed to a tumor. But as I'm going to show you in the next few slides, unfortunately, your body is not doing this. And the tumor has developed some pretty significant ways to circumvent this whole immune response. So I'd like to highlight 4 mechanisms that are deficient, and I'm going to make it focus just in lymphoma, but it's important as you're listening to this that you're thinking about the fact that all 4 of these, and there are others, are mechanisms that we have to overcome if we want immunotherapy to work effectively. So the first thing that I'll show you some data on in a minute, as I mentioned to you, the key first message is MHC molecules presenting tumor antigens to the T cell receptor. And this T cell receptor often cannot effectively recognize tumor antigens because they are not really presented in a true effective manner, because MHC molecules in lymphoma are often downregulated, lost, or mutated. So the antigen presentation is ineffective. The second problem we touched on a minute ago, and that is you may have effective presentation, but you need a second signal, and the second signal needs to be an activating signal. Many times the tumors have got smart. They've worked out that if they provide an inhibitory signal, it will shut the immune system down. So overexpression of PD-L1 or PD-L2 on tumor cells or in the microenvironment will immediately provide that negative signal. Third issue is the fact that many cells that are in the environment are actually recruited in. Remember, of course, that lymphoma is actually part of the immune system. Malignant B cells are still B cells. They still talk to the environment, and they recruit in other cells, and many times they kind of bring in a bad neighborhood, if you like, where there are many other cells around, rather than promoting an anti-tumor immune response or suppressing the ability of effector cells to work. And finally, I'll show you some data around cytokines. We often regard cytokines as good things, but remember that either cytokines can, just as easily as they can be activating, they can be inhibitory. And second way in which they can sometimes be unhelpful is too much of a good thing. If you continually stimulate a cell over and over and over and over again, it becomes immunologically exhausted. So I'm going to show you data that support all of this, and then I'm going to show you strategies in which immunotherapy is working to overcome these deficiencies and get us back to that effective anti-tumor immune response that we said was our goal right at the beginning. So the first thing we said was that antigen presentation is really critical in the context of MHC class 1, class 2, beta 2 microglobulin. So the first point to make that I think is very important is that particularly if you look in diseases like Hodgkin lymphoma, but the same is also true in diffuse large B-cell lymphoma, as I'll show you on the next slide, many times there is loss or downregulation of these molecules. So this is data from the Dana-Farber group, and you can see they specifically are doing, this is in Hodgkin lymphoma, staining for MHC class 1, class 2, and beta 2 microglobulin, which are the components of the presentation machinery. And shown down here are 5 different cases, but I think the most informative thing is to look at this analysis of a large number of patients, and the black that you can see is when there is positive expression of all of these particular molecules. And you can see it's just a minority of cases. Most of the cases actually have some degree of either negativity or decreased expression, suggesting that most of the tumor cells, the Reed-Sternberg cells in Hodgkin lymphoma, have something wrong with the amount of expression of MHC class 1 or class 2, suggesting that antigen presentation in Hodgkin lymphoma is a significant challenge. This is data, and it's now actually quite old data, from diffuse large B-cell lymphoma, focusing here on MHC class 2 molecules. But you can see that there are a sizable percentage of patients in whom it is downregulated, and what's important is to see here in panel A the risk of dying relative to the expression of MHC class II molecules is significantly upregulated or increased when you have less expression of MHC class II. So in large cell lymphoma, lack of adequate antigen presentation is actually associated with a worse outcome. So the first issue that we said was really important for an effective anti-tumor immune response was good presentation of the antigen, shown here in both Hodgkin lymphoma and large cell lymphoma and other lymphomas. That can often be deficient. Problem number one. Problem number two, we touched on a moment ago, is tumor cells in their quest to stay alive are smart. They upregulate things that protect them. So here are those suppressive ligands. So remember we said first message comes through the MHC molecule interacting with the T cell receptor. Then you need an activating signal to actually make that cell do its job. If the T cell receives a negative signal, it will downregulate its function and, as it were, go to sleep. So is there evidence for that? And all of us in the room, I'm sure on the line, would be quite familiar with the fact that absolutely. Shown on the left again is Hodgkin lymphoma. Shown on the right is diffuse large B-cell lymphoma. And you would be quite familiar that in Hodgkin lymphoma, there is overexpression of PD-L1 and PD-L2 driven by either copy number gain, as shown in the top left here, or amplification, shown in the top right. That results in high expression of PD-L1 on you, as you can see here on the Reed-Sternberg cells, or PD-L2. So your tumor cell is packed with negative ligands to suppress the anti-tumor immune response. In large cell lymphoma, little different, not quite as much expression on the tumor cells. You can see here an analysis looking at the little blue lines are expression on tumor cells, and you can see a subset of patients where that is very high. You can see that the remainder of cases can have increased expression, but in this case, the expression is commonly on macrophages within the microenvironment. However, there is probably a similar effect from both of those sources, and the effect is seen here. When you looked at cases that have pretty high expression of PD-L1, you can see those large cell lymphoma patients had a worse outcome compared to those that were PD-L1 low or PD-L1 negative. So again, message here is, aside from the antigen presentation, receiving a negative signal right away provides you with an inhibitory signal rather than an activating one, and a worse outcome for patients. Well, you might say that's fine and well, but how do we know the effector cells are susceptible? Because clearly it doesn't matter if you have high expression of PD-L1 if the T cells are not really going to be affected in any significant way. Here are data just to show that PD-1, obviously the receptor for PD-L1, is highly expressed on many intratumoral T effector cells. And in fact, many of those T cells also express other inhibitory receptors, making them very susceptible to immune exhaustion. And you can see that here, looking at the component of the CD4 cells. You can see this population here of PD-1 positive, TIM3 positive cells, and in the CD8 fraction, this population of TIM3 positive, PD-1 positive cells, who are very likely to be exhausted cells. Now, the astute people in the audience would go, well, here are a whole bunch of PD-1 positive cells that are not TIM3 positive cells. Just reminding you, and I'll circle back to this a little later, that PD-1 is not only expressed on cells that are susceptible and immunologically exhausted. These are T follicular helper cells. And again, the effects of PD-1 signaling will be potentially different. But to take us back to these cells, these are the ones we worry about. These are the ones that are activated. Our goal is to see those cells kill the tumor. And the challenge is they have a receptor that makes them susceptible to that PD-L1 that's highly expressed on the tumor. So does it matter? Well, shown here in these white bars, each of these little peaks is a proliferation. So what we're doing is we're taking the T cells, we're stimulating them, and we're showing that they are able then to proliferate, showing that they're healthy and in good shape. If you then compare the ones that are PD-1 positive and TIM3 positive, that's these gray ones, you can see there's very little proliferation. So in comparison, the ones that don't express PD-1 or don't express TIM3, they are active and proliferate just fine. The ones that express PD-1 and TIM3, they are potentially very susceptible to suppression, and you see they're not proliferating at all. Similarly, if you take the CD4 cells and you look at these cells, the ones that are TIM3 positive and PD1 positive, are they able to make macrophage? Are they able to make cytokines? You can see they are very inhibited compared to their counterparts. Similarly, if you take the CD8 cells and you look for the ability for them to make effector molecules, these are the things that punch holes in the tumor and actually kill them like granzyme. They can't do that. And their STAT signaling is very limited. So you might say, well, what does all of that mean? Well, inside your tumor, in a lymphoma, you have T cells wanting to go, but having receptors that make them very susceptible to the PD-L1 signaling. And in those cells, they are very much suppressed by PD-L1 signaling, making them ineffective and unable to really target the tumor. That data I just showed you was from our group. Here is some data from other groups, really just showing that. The data I just showed you was predominantly in follicular lymphoma. Here is data in large cell lymphoma. This assay, the cell trace, is really just looking again at that ability for each of those peaks as it gets dimmer. And you can see in lymphomas, these cells are not able to proliferate very well compared to controls. And what they showed here was more of these cells, these TIM3 positive, PD1 positive, in this case CD8 cells, the greater the number of those, the less these cells are able to proliferate. So they are inversely proportional. More of them, they don't proliferate very well. And cytokine production, the more of those you have, the lower your ability to make gamma interferon, which many people will know is very important in an anti-tumor immune response. So what I hope you're hearing, we said the first point was MHC molecules are deficient, so antigens are not effectively presented. Second point is many times there are inhibitory ligands such as PD-L1, PD-L2 on the tumor cell, and importantly, susceptible cells in the immune environment that could be suppressed by those ligands. So the third issue is, well, we've got a lot of immune cells present in the tumor. Why are they not helping? Why are they not eradicating the tumor? So I just wanted to highlight here, this is a case of follicular lymphoma. Those that have a pathology experience in the audience will know that if you look here you can see these pseudo follicles in follicular grade 1/2 non-Hodgkin lymphoma. If you were to stain for CD20, there would be very bright and diffuse staining with all the malignant B cells. But the focus here was, what about other immune cells? So you can see here is CD3 staining the T cells, and you can see an abundance of T cells present in follicular lymphoma. Similarly, if you go looking for follicular dendritic cells using CD21, you can see that they form these meshworks right in these follicles. So there are many other immune cells present. And in fact, we did some enumeration of that in probably 2 decades ago and showed that, probably somewhere between 20 and 40% of the cells in follicular lymphoma are not malignant cells, but are immune cells. So those must be helpful. How are they fighting the tumor? So if we dig a little deeper, we now focus in on one of those follicles and look to see, are there T cells, CD4, CD8 cells right in the follicles, suggesting that hand-to-hand combat is happening now with those particular malignant cells. You can see both CD4 and CD8 cells right in the tumor. However, even though you would know that more immune cells are associated with a more favorable outcome, it is not a situation that those cells eradicate the tumor. Slowly over time, most patients, in this case with follicular lymphoma, will continue to have evidence of disease progression. So what's going on? Well, the first thing that's going on is the cells we're looking at. Let's start off looking at CD4 cells. Many of them are actually not helpful. And in this case, I'm going to highlight that many of them are regulatory T cells. In other words, their job is to regulate and control and often dampen the immune response. So back to the same follicle, now staining with FOXP3. So we're looking to see, are these Treg cells, and you can see a very high percentage of the CD4 cells that we could see within the tumor are in fact Treg cells. So you might say, well, how do we know that's more than normal tissue? And shown across the top here is looking at tonsil, reactive lymph node, and then lymphoma. And you can see that it's a more pronounced population in the case of lymphomas. But more important than how it looks is, are those cells suppressive? So to test that, we take those cells and co-culture them with other CD4 cells that are not Treg cells. We activate the other cells, and then we look at their ability to make cytokines in the presence or absence of the Treg cells. And you can see that if you activate those cells, you can get a sizable amount of gamma interferon and IL-4 made, provided there are no Treg cells. If you start adding in the Treg cells, you can see that the ability to make cytokines is substantially decreased. The second thing, we did this experiment before, I showed you some data, but let me show it to you again. If we take, in this case, CD4 cells and activate them and look for their ability to proliferate, so as they proliferate, they make one of these peaks, and you can see cells are quite able to be activated. And if you just add irrelevant T cells, not Treg cells, they proliferate just fine. If, however, you add in Treg cells, you can see that proliferation is substantially blunted. So again, what is this telling us? If you have a lot of Treg cells present in your tumor, they are not innocent bystanders. They are suppressing the ability of other immune cells to make cytokines, to proliferate, and to do the work of targeting the tumor. Further point to make is that when we're talking about other cells that are present, it's not just Treg cells that are an issue. Macrophages are often very abundant, and macrophages are commonly very immunosuppressive and therefore contribute to the inhibitory environment. Here is now a staining for CD68, but you could do this for CD163 or one other markers, and you can see that there are a lot of macrophages present within the tumor. Those macrophages also make a lot of cytokines, and I'm going to circle back to cytokines in a minute. I'm highlighting here the ability to make IL-12. IL-12 can be immune stimulatory, but I'll show you in a minute, sometimes too much of a good thing is actually a bad thing. Furthermore, if you take the ability of cells to proliferate and you add macrophages, this is the tumor cell, the ability of the tumor cell to proliferate, adding macrophages really helps them grow. So macrophages here again are not innocent bystanders just in the neighborhood. They are actually facilitating the tumor cells. And when we've done mouse models where we take those tumor cells, add macrophages or not, and implant them into a tumor, you can see if macrophages are present, the tumor implants much faster. So macrophages again are actually having a direct effect on the tumor cell itself. As counterpart of the macrophages are what we'll call myeloid-derived suppressor cells, MDSCs, and these cells are very suppressive of effector cells. So you're going to hear this message over and over again, effector cells with all of these different mechanisms that are suppressing their ability to do their job. So how do we know these cells are present? This is in bone marrow. We're looking at patients with lymphoplasmacytic lymphoma or Waldenstrom's macroglobulinemia. We're looking specifically at those that are lineage negative, looking then at the ones that are CD33 and CD11B positive. And then we can actually show two different types, those more of macrophage lineage and those more of granulocytic lineage. And you can see those, some of them express the PD-L1 that we spoke about before. If we were to compare normal bone marrow to Waldenstrom's bone marrow, you can again see that in each case, there are more of these cells present. And then using the same assay as we did before, we looked at the proliferation of T cells on their own, and you can see at least half the cells will proliferate. If we add in monocytes that are HLA-DR high, in other words, they are not these, so in other words, they are these cells, not these ones, they don't really do anything. But if you add in these suppressive cells, you can see there's no proliferation at all. So the three things I'm hoping you've heard so far: antigen presentation deficient, inhibitory signals through PD-L1 very prevalent, and lots of other cells in the environment that are no help. Treg cells, macrophages, myeloid-derived suppressor cells, all of these conspiring for a very inhibitory environment in lymphoma. Final thing that I wanted to talk about is, what about cytokines? So again, remember, we've had a focus so far on cells, but what about if there are a lot of other proteins that are being circulated around? Could they affect the function and the outcome of the immune response? So again, I just wanted to take us back to these myeloid-derived suppressor cells, or HLA-DR low monocytes. You can see much more prevalent in lymphoma. Remember, I told you that they are associated with less proliferation. But here's the thing I want to highlight is that IL-10, the more of this that you add, you actually have an increased percentage of these HLA-DR low and CD14 expressing macrophages. And you can see here that this matters because if you look at the serum of patients with lymphoma, IL-10 is often increased, so it really promotes these macrophages. The second problem in which cytokines are a challenge is, I mentioned this before, they can be inhibitory or they can overstimulate the immune system. So here are data for both of those. This is TGF-beta. When you activate T cells with TGF-beta, you actually get upregulation of CD70, suggesting that you've activated them. However, when you look at those CD70 positive cells, you can see they commonly express all the things we just said were bad. PD-1 expression, TIM3 positive expression. You can see their ability to proliferate just went down, and they make far less in the way of cytokines. So you kind of poke the cells, but not in a good way. Those cells are now much more suppressed, exhausted, and dysfunctional. A further thing, and we touched on this a little bit before, but I think it's important again to remember this, IL-12, it's a T cell activating protein, but if you look at patients, this is follicular lymphoma patients, those that have IL-12 above the normal range, you can see their outcome is worse than those that have normal levels of IL-12. So you might say, well, how is that? You're supposed to now, if you have more IL-12, you have more T cell function, this should be good. This is a little bit like continually kind of pouring gasoline, petrol on the campfire. You get lots of blaze, but it doesn't last very long. And so what happens is you keep activating the cells, and then over time, you can see this TIM3 PD-1 positive population gets bigger and bigger as the cells become more and more exhausted. So what do I want to just summarize out of this information that we've got so far? So my goal today is to show you, what are we striving for? The immune response, the perfect immune response. What does that look like? What's wrong in lymphoma that we need to overcome? And you heard me say 4 things. Antigen presentation wasn't very good. Inhibitory signals through PD-L1 was very prevalent. Other cells like Treg cells, macrophages, myeloid-derived suppressor cells suppress the environment, and cytokines kind of bathe the whole thing, but many of them are inhibitory and others of them overactivate the immune system and eventually just exhaust it out entirely. So that's what's shown in this image here. You can see you've got your effector cells here. These are the ones you want to do the work. You want them to go after the tumor and kill it off. But many of them are exhausted. They have these inhibitory signals that actually are shutting them down. Many of the cytokines that are around are wearing these guys out and activating inhibitory cells, which are actually directly suppressing effector cells. And in fact, the tumor has got kind of smart. It's got PD-L1 to shut down these guys and is actually directly promoting the abundance of these inhibitory cells in a further attempt to shut things down. So we need to think about reversing T cell exhaustion and overcoming immune suppression as our strategy for how to treat patients. So with that in mind, what exactly can we do? What are the strategies that we could focus on that can be therapeutically beneficial? Some of these might be available to you. Some of these are strategies that are coming, but I want you to think about immunotherapy now in the context of what deficiencies are we trying to overcome and where are we trying to go as far as the perfect immune response is concerned. So strategy number 1, remember we said a lot about PD-L1 and or PD-1 signaling and all of these inhibitory signals. So shown here is the immune checkpoint, and this is only a partial graph, it's kind of a slide that's getting older now because there are many of these. Shown on the left are all of the inhibitory signals. And you heard me talk about LAG3 and PD1 and TIM3, not even listed here. All of these are inhibitory signals. So when the T cell receptor is getting its positive signal, if it was to get an inhibitory signal, that would be shutting it down. So if we block these inhibitory signals, we could prevent that. Similarly, at the same time as receiving this positive signal, there's also an additional positive signal, the second signal, commonly through CD28, which could actually be able to make that cell get activated. There are a bunch of other positive signals, a lot of them listed here. So if you actually provided additional positive signals at the same time, you could further activate the immune response. So does this work? Is this a feasible strategy? Well, most of you would know absolutely right. Yes, it is. Here is data from Hodgkin lymphoma using PD-1 blockade. And I'm showing you two patients that were actually treated in the initial phase 1 clinical trial of Hodgkin lymphoma treated with nivolumab. And I show you these two cases because I think they're really interesting and informative. This patient shown on the left here is a 42-year-old patient with Hodgkin lymphoma who has a lot of intra-abdominal disease here. And you can see both of these sets of scans were done 6 weeks later. So after 6 weeks of treatment, 3 doses, you can see that this patient has had a dramatic response with no disease visible in the abdomen on the PET scan. Now the astute clinician in the room would go, but I see you had some FDG uptake here in the chest, and that really doesn't look that much improved. Clearly that's not benefit. Well, it was very interesting because this lady had her valve replaced right around the time when she was diagnosed and was still kind of healing up. So this is interesting because clearly the blockade of that inhibitory signal had a profound effect on what was happening in the tumor, but it didn't really inhibit many of the cells that were part of the healing process. So again, I showed you before about exhausted cells being susceptible. If you have healthy activated cells, their susceptibility is very modest. This patient was a patient that I treated who was going to hospice. They had decided he had no more options left, but his mom called up and said, do you have anything for this patient? And we said, we've just opened this trial if he would like to go on it. 26-year-old young man. So he goes on the treatment and he calls me from his car on the way home and says, it's working. And I go, well, yeah, right. How would you know that? He said, I used to itch like crazy. My itching's gone. And he was completely correct because 6 weeks later, he was in a very good partial remission with just a little bit of FDG uptake in his axillae. The point I would make there is that it's very interesting that instead of his T cells going wild and him getting a lot of cytokine release and all the rest of it, he immediately got better, suggesting that something was switched off rather than switched on, which again just reminds us that we don't know everything about PD-1 blockade. So how well does PD-1 blockade work? I showed you some data there from the nivolumab trial. Here I show you the longer-term follow-up of the larger pembrolizumab trial. Many people on the call will know this, but the response rate showing between 65 and 75%, regardless of the different category that you might have been in, post-transplant, brentuximab vedotin treated, not treated, and you can see that the responses are quite durable. I want to point out one other thing that I think is very interesting. You can see here that there is no plateau on this curve, suggesting that even though patients may durably benefit, we're not convinced that we are curing people with this therapy. And we're not. Remember we said we needed immunological memory. It's not clear that we are generating immunological memory. There are a number of new PD-1 antibodies that are now available. I highlight tislelizumab here, really because I think one of the things that's very interesting about this molecule is that very high response rate, 86%, but most importantly, really high encouraging result here with 63% of the patients having a good response and being in a complete remission. So a few lessons learned. The first thing I think that's really important to know is that PD-1 expression or PD-L1 expression predicts response to PD-1 blockade. So here are data from Hodgkin lymphoma. I think the important thing to note is that copy number gain and amplification are seen in the vast majority of cases. And this results, as you can see on the bottom, with increasing expression of PD-L1 by this H-score. And those are the patients that seem to have the best results as far as outcome is concerned, shown here. So I think we can say that if you know you have a genetic reason, PD-L1 amplification or PD-L1 copy number, in Hodgkin lymphoma, as and also show you in other diseases, that clearly is associated with disease response. So that bears out in patients with primary mediastinal large B-cell lymphoma. Here we can see the two trials that have been done and the data that have been aggregated. But as you might know, about 40 to 50% of cases have amplification of PD-L1 and PD-L2. And you can see again the response rate corresponds with that. About 48% of patients benefiting, and again the most typical response is in the patients that have chromosome 9p24.1 genetic variability. Similarly, you can get further likelihood of response if there is a viral reason for there to be overexpression of PD-L1 and PD-L2. And you can see that here. You can see this is a disease with NKT cell lymphoma, a small series of 7 patients, but 5 of them having an excellent response to therapy. So the takeaway for me is, if you have a genetic reason, copy number gain, amplification for overexpression of PD-L1, PD-L2, you're going to then most likely have a response to therapy. If you have a viral reason for overexpression of PD-L1 and PD-L2 like EBV, you will again have a high likelihood of response. In contrast, if you don't, so here are data for follicular lymphoma for patients receiving nivolumab, you can see the overall response rate was very disappointing and the duration of benefit was exceedingly short. So again, not having those two factors associated with a far less favorable benefit from therapy. Here are data for large cell lymphoma that are equally disappointing if you just have an unselected large cell lymphoma cohort. Overall response rate in patients who relapse after transplant was only 10%. For patients who were primary refractory, only 3%. So again, really not very beneficial in the vast majority of patients. However, in the subsets of patients where PD-L1 amplifications were identified, those patients seem to have a greater degree of benefit. So why might that be? And I think it's important to recognize that there are some complicating factors that have taken what we thought to be obvious and just made it a little more complex. And I want you to think back to what we just spoke about the immune response and exactly what we're doing. So remember I showed you that cells that have PD-1 expression, TIM3 expression, and as I'll show you now, LAG3 expression, so multiple inhibitory exhaustion markers, those cells are very susceptible to inhibition. But not every cell that has PD-1 on it is actually an exhausted cell. Some of them are activated cells, and as I'll show you right here, some of them are T follicular helper cells. So you can go back here to the follicular lymphoma case, and you can see this very bright expression of PD-1 in the follicles and very dim expression in between, highlighted here. And in data that we and others have shown, these are the exhausted cells potentially between the follicles, but the bright ones in the follicles are actually T follicular helper cells. Surprisingly, if you look at the ability of cells to get active and to make cytokines, those that are PD-1 expressing actually make more cytokines than those that are PD-1 negative, because many of these are activated cells. So remember, the natural physiology is as cells get activated, PD-1 will go up. That's normal. However, as shown here on the right, when they start to express many other exhaustion markers, like LAG3, you can see that those are the cells that really have great difficulty in proliferating or making cytokines. So the LAG3 positive cells, if we're looking for the ability of them to make gamma interferon or IL-2, you can see very few cells. In contrast, the ones that are LAG3 negative but PD-1 positive, suggesting these are activated and not exhausted, you can see far more in the way of their ability to make cytokines, and that's shown on the panels here below. A second complicating factor that I think is important to know is that, remember we said if we're going to block an inhibitory signal, you need to get an activating signal at the same time. Many of the tumors, many of the T cells within the tumors actually have downregulation of co-stimulatory molecules. So we're looking here at tonsil compared to follicular lymphoma. And we're looking for this bright red color for CD27 and CD28, the stimulatory molecules. And you can see it's much brighter in healthy tissue than it is in follicular lymphoma. And that's shown over here. You can see the number of cells that have limited or no expression of CD28 or CD27 is virtually absent in tonsil, but is quite sizable in follicular lymphoma. And the reason that matters is those that have decreased the expression of CD28 and CD27, those patients do much worse. So you might say, well, how does that work? Well, a few papers that came out a few years ago explained that if you block signaling through PD-L1, you shuttle a lot of the signaling through CD28. And that's how PD-1 blockade works. The problem, however, is if you don't express CD28, doesn't matter then if you block PD-1, there is no shuttling mechanism. It doesn't then allow for you to have the activation you require to overcome the PD-1 suppression. A second complicating factor that I think is important to be aware of is we think about cells touching each other, and that's how the signaling happens. This is data also just to show you that PD-L1 and PD-L2 can be shed. So you can see here in Hodgkin, PD-L1 and PD-L2 is actually quite highly expressed and can be detected in the serum. And then if you take this serum and you co-culture them with T cells, you can see that it can very easily suppress them, and you can see affects their signaling and has an inhibitory effect as shown here on their metabolism. So important to know is it's not just what's happening in the tumor, there's actually effects that are happening at distant sites. And a final thing that even complicates it more, here is data in Hodgkin lymphoma. Now, fair enough, this is cell lines, but looking at PD-L1 expression, but now using an antibody that instead of being a blocking antibody is an activating antibody. So when it binds to the tumor cell, it actually makes the tumor cell grow. And PD-1, again, can be soluble in Hodgkin lymphoma. So shown here is if you take these cells, you treat them with PD-1 soluble, let them bind to the receptor, and the receptor and the ligand bind, you actually get a reverse signal, a positive signal that goes back into the tumor that makes the tumor cell much more active, and you can block that with the use of nivolumab. That would suggest that really there's an effect that is T cell independent when it comes to PD-1, PD-L1 interactions. So that was strategy number one, working to block these inhibitory signals. Strategy number two, I'm going to spend a lot less time on just because that's another whole topic, but that's, remember we said, the problem with antigen presentation. If you're not presenting antigen, your T cells don't know what to go after. So can you help with that? And that's where CAR T cells come in. So remember, this process is all deficient. So if you actually replace this T cell receptor MHC interaction with an antibody binding motif, and you built in a co-stimulatory molecule right into the complex, when it sticks onto the tumor antigen, it would automatically activate the cell and make that T cell really mean and nasty and make it go after the cancer cell. And as you would well know, I'm just showing you a little bit of data here from the Transcend study, but if you see responding patients, particularly those that have a complete response, there are very durable benefits, and there have now been some preliminary results in the way of press releases provided to say that even in the case of comparative studies with transplant, this may be a more effective therapy. So I think using a novel way to recognize the tumor away from the tumor antigens and just using receptors or molecules like CD19 and a co-activation process at the same time is highly effective as immunotherapy. Third strategy, again, would be to overcome many of these inhibitory signals that we spoke about earlier by forcing activation. And how might you force activation? Well, if you bring these cells in very close proximity, you would be able to do that in an effective fashion. So you can see here that this is a number of different monoclonal or bispecific antibodies. you can see that there are some that are kind of got a more typical structure. There are some that are duomabs. There are the ones that have a 2-to-1 or a BiTE or tandem molecules. These are all ones that are currently available for treatment in patients with various lymphomas. But in principle, what they're doing binds to CD20 and binds to CD3, brings those cells really close to each other. When that happens, the two cells get very grumpy, and when that happens, there's actually progressive killing of the malignant cell. So does this work? Original data was with blinatumomab, which many would know is an approved treatment in ALL and other malignancy leukemias. But in lymphoma, about 70% of large cell lymphoma patients benefiting from this therapy. The challenge with it is just the infusional nature of this treatment. So there are a number of new bispecific antibodies that have been recently discussed and presented. This is mosunetuzumab, and you can see this is a CD3, CD20 molecule, and the response rate here, about a third of patients, many of these CAR T-cell failures, which again has been a promising treatment strategy. Then there's the odronextamab. This again is a CD20, CD3 bispecific, and again the response rates here have been very promising. About 60% of patients benefiting at the optimal dose, and about 45% of patients benefiting, particularly in the CAR T-cell space. So showing that even if your CAR T-cells are failing, if you can pull the CAR T-cells and other T-cells right up close against the tumor, you can make them kind of regain some of their effectiveness. A third strategy would be, could you actually take NK cells and macrophages and get them to do their job? So remember, we said we got all these bad cells around, macrophages, but we know they express CD16. So this molecule, the AFM13, is a CD30, CD16 bispecific molecule. Grabs onto CD30 diseases, but brings up close macrophages and NK cells. And this has been tested in Hodgkin lymphoma in a combination study with AFM13 and pembrolizumab. This was published last year. And you can see that as we got into the effective dose levels, the response rate was 85% with many complete responses. So this, I think, is an important and useful strategy, but it will be needed to be tested in a randomized controlled study. Two more strategies I'd like to talk about. This is now engaging those macrophages in a more efficient fashion. And this is bringing the innate immune system rather than the adaptive immune system and using them. So many would know that tumor cells, aside from the PD-L1 expression that we spoke a lot about, also have other don't eat me signals on them. So as cells get older, as cells become malignant, they start expressing things like calreticulin, which are eat me signals, and macrophages would eat them up. However, if they express things like CD47, that provides a don't eat me signal that goes through SIRP-alpha, and then the tumor cell gets a break. If, however, you were to block that with a CD47 antibody, or in this case, a SIRP-alpha FC, this is a decoy antibody, that would actually promote that eat me signal and take away the don't eat me signal. The macrophage would eat it up, would process all those antigens, show it to the T cells, and aside from having directly eaten the T cell or eaten the tumor cell, get the T cells to do their job. So this just shows you that in the lab this works. Here's that 47 don't eat me signal, very highly expressed on tumor cells. If you block that, you could get all kinds of macrophage eating. This just shows it across the bottom. This is control antibodies. You can see no eating going on. If you use things like rituximab, macrophages will do some, but if you then block CD47, you can see it's much better, and if you do the two together, it's even better yet. So does this work in the patient? Absolutely. These are data from Stanford for the original study with 22 patients, a combination of a 47 blocking antibody and rituximab. And you can see that, again, overall response rates were very promising in follicular lymphoma and in large cell lymphoma. This has actually led to a provisional approval of this strategy for treatment of large cell lymphoma. Similarly, I showed you the decoy receptor. This is in large cell lymphoma, and you can see again just an example of a number of patients responding. The response rate here was about 25%, but you can see that even in double hit lymphomas, as shown in this patient, good responses seen in combination with rituximab. Interestingly, responses are also seen with T-cell lymphomas. So here is an example of 5 patients with Sézary syndrome who benefited in the phase 1 trial of this agent. Final comment was then to talk about using immune checkpoint therapy in combination. So really just briefly say there are some combinations that work and others that work less well. So here we're using 2 inhibitory checkpoints, CTLA-4 and PD-1, and the bottom line is not very effective. Here is an immune checkpoint for NK cells, and again, not particularly effective. So I think just simply taking away negative signals may not be enough. Here is using an antibody drug conjugate, and you can see this is brentuximab vedotin plus nivolumab, and you can see response rates very high here, 82%. So that breaks down the tumor and exposes more antigens for tumor presentation. And then finally, if you combine it with chemotherapy, could you get better results? And this everybody might be familiar with. This is nivolumab plus AVD chemotherapy, and you can see a very high response rate, and this is now being tested in frontline therapy for Hodgkin lymphoma patients. Similar data also being generated in large cell lymphoma with the use of pembrolizumab with R-CHOP. Again, this will require a randomized study, but a very high overall response rate seen here. So what does all of this teach us? I think the first thing for us to appreciate is that there are many immunological barriers to an effective anti-tumor immune response, and as I've shared with you, the biology is quite complex. However, if you have a genetic alteration of chromosome 9p24.1, those are the patients that clearly benefit from PD-1 blockade, and important to know, PD-1 blockade can actually affect different T cells differently. So therefore, we need to really understand that biology to understand who would benefit best. However, other strategies, if we can bring T cells close together with improving immune synapses, if we can overcome some of the defective antigen presentation with CAR T cells, those are highly effective strategies that are likely to be the future. But the future, I think, really will be the use of combination approaches, not only working on the adaptive, the T cell immune response, but also the innate, the macrophage immune response, or a combination thereof, and combinations that include cytotoxic agents. So with that, I'd like to end. I'd like to thank the lab members that generated some of the data that I showed you, the folks that fund the money or give us the money to do the research. But most of all, I'd like to thank you for inviting me and thank you for your time and attention. So with that, I'll end and thank you very much.
Thank you, sir, for that masterly presentation. So much of work has gone in understanding this complex problem. We have some of the people here who would like to ask you some questions on their difficulties. Dr. Abhishek.
Sir, excellent presentation. Indeed, it was enthralling to see how deep people work into immunotherapy. I'm a medical oncologist. One quick query which I always have is, like in solid tumors, why don't we use PD-L1 as a marker in hematolymphoid malignancies? Like testing every patient for a PD-L1, he's high expressor, give him the immunotherapy right up front. Because practically we are landing up in immunotherapy in most solid tumors by doing PD-L1 up front.
So it's very interesting. A lot of the lessons we learned in solid tumors haven't translated very well into hematological malignancies. Part of the problem is when you have a genetic reason for overexpression, like we see in Hodgkin lymphoma, virtually all the patients have that. PD-L1 is screamingly high, and those patients clearly benefit. But if you look at the data that was generated from large cell lymphoma, where PD-L1 expression can be kind of more diffuse, and many of them are not genetically overexpressing, there is actually no correlation between the PD-L1 expression and the likelihood of benefiting from treatment, just as far as the IHC is concerned, like there is in solid tumors. So that's why you don't see a H-score or a recommendation for staining, because it's not clear at this point that there's actually an association between expression in the tumor in general. The only people that really seem to benefit are the ones that have genetic reasons in the tumor cell, and the expression is just on the tumor cell itself. So in the heme malignancies, there has not been a companion diagnostic, if you like, much though we would love to have that. And you're right, we would love to be able to know who to give it to. And the point I would make is we're not that far along.
So wouldn't that make life very difficult for immunotherapy in hematologic malignancies? So you don't know which are the particular subset of patients you should be targeting?
I think that's exactly right. I think that's exactly what's made it very hard for us. And I think you can see there's sort of a struggle going on. With the beginning, it was all super exciting and everything was working out. And now we're all kind of like, I'm not too sure. So I think your point is excellent and very well made.
Thank you. Gunjan.
An excellent talk, sir. Thank you very much. My question is regarding the combining the anti-angiogenesis therapy with the PD-L1 inhibitors. Any role of anti-angiogenic therapy?
Yeah, that's a very good question. And to be frank, that's not really been tested very much. So I think that's a potential future strategy to consider. They're very different mechanisms, very different reasons. There's obviously recruitment of cells that gets influenced. So I think that's something that should certainly be looked at in the future. Our problem in hematological malignancies has been that angiogenic agents have kind of gone into the back burner a little bit. So people haven't really explored that. So I think that's a future thing that we really need to be thinking about.
One question from the audience. Can PD-L1 blockers be continued indefinitely or for 2 years fixed treatment like we do in solid tumors?
Yeah, very good question. I think it's kind of interesting if you go to Hodgkin lymphoma, how we kind of came in a circle. So we started off going, well, I'm glad it's responding, but we're planning to go to an allogeneic transplant. Then a lot of people really benefited and got to be super well. And people went, well, maybe it's curing everybody. We don't want to do allogeneic transplants. And then it got to, well, no, now they're all relapsing. So, maybe we should do allogeneic stem cell transplants. So quite frankly, the optimal duration of treatment is pretty much unknown in lymphomas in general. There are some data, though, that says if you achieve a complete remission, you can stop your treatment. And then if it comes back, you can always restart and regain the remission. So in my practice, I try and treat the patients. If they get a CR, I treat for maybe another 2 or 3 months just to feel like I really have got them in a good remission. And then I give them a break and I wait to see what happens. But as far as 2 years and stop, no one's tested that. And I think quite honestly, in the practice, in like Hodgkin, when patients are young, folks are really anxious to stop treatment and run the risk of the disease coming back.
Dr. Aishwarya?
Thank you, sir, for the talk. My question is, when do we and how do we sequence the PD-L1 inhibitors in relapsed cases, considering the limited financial resources and the treatment options we can offer to the patients in India?
Yeah, that's a very good question. And I think, again, it's important to remember that treatments that have been around a long time and that are way cheaper are still highly effective. So the ABVD and the BIACOPs of this world continue to still give very, very good results. So if there are resources that are more limited, I would say that the use of PD-1 blocking antibodies, I would keep for later in the disease course. Because at this point, we don't know how much that improves the outcome over more standard treatments like ABVD chemotherapy. So in a limited resource setting, let's say we have a large cell advanced stage Hodgkin patient, I would give ABVD chemotherapy, drop the bleo after 2 cycles if they're doing fine, and wait to see how they do. If they were to have disease come back, I would even consider an autologous transplant and then consider PD-1 blocking antibodies, because I think, again, they're very expensive and the return on the investment is substantially less.
So can I just ask another one? So just taking this forward, like we have a pediatric Hodgkin's who's refractory to second-line therapy also. So we offered the options right now was like we gave him the option of brentuximab or nivolumab. So like how should we go about it? That how to decide which one, and again the sequencing for the same?
Yeah, so I mean, there's been a comparative study of brentuximab versus PD-1 versus pembrolizumab post-transplant and shown that the benefit is greater for the PD-1 blocking antibody. So I think in my practice, I would use a PD-1 antibody first. I would use brentuximab vedotin subsequently as a single agent. However, there are also now a number of circumstances where we are using combination approaches with, for example, brentuximab vedotin plus salvage chemotherapy, or brentuximab vedotin as upfront therapy. So I think if you already had it as an upfront therapy, then I would probably not give it at a later point, particularly if you progressed on it. But if you didn't, I think I would sequence a PD-1 blockade first, brentuximab vedotin after.
Hemant?
Thank you, sir.
Dr. Ansel, many thanks for a wonderful talk. My question is that is there a rationale for combining radiation therapy with checkpoint inhibitors, say like exposing the antigens and making a cold tumor hot?
Yeah, so that's a good question. And the answer is, it seems to me that yes, there is. However, no one's really done the randomized comparison of PD-1 blockade plus radiation versus radiation alone. And so I think that needs to be done. I think there's a lot of good data to say that, you know, the abscopal effect is going to be potentially beneficial. That could be augmented by PD-1 blockade. But aside from small little series, we have not had any kind of randomized comparison to test that. The other problem we have is, you know, in Hodgkin lymphoma, the results are so good that it's good and gooder, you know, and it's very difficult to be able to tell good and better. And that often takes very big studies that no one's that excited about. So your point is excellent. The results are just, and the data are just deficient.
Amit?
Sir, wonderful talk. Sir, like brentuximab in post-transplant Hodgkin's lymphoma maintenance based on the Athera trial, same holds true here also? Does it hold benefit in maintenance post-transplant? PD-L1 blockade?
Yeah, so there's only been a limited study and it has not been a randomized trial like it was in Athera. So we have to be cautious about interpreting that data. But that group, that was actually published by Philippe Armand, and what they had said is that they expected at least, I think it was 75% progression-free survival at 2 years. And what they did was they then treated I think about 30-something patients and showed that the 2-year progression-free survival was actually like 85%. So they did feel it was significantly beneficial. However, you could argue patient selection matters and a lot of other things, and because that was a single-arm study, we really have not had in the consolidation post-transplant space the same trial done. So I think in my practice, if people have not had brentuximab vedotin and I have access to it, I will use it post-transplant as a consolidation. I will be honest with you, very few people get all 16 doses. Most people kind of get the neuropathy at about 10 or 12, and then we typically stop. But that's where I would use that. I would save the PD-1 not for in the time when the patient is in remission, but for when the time, heaven forbid, but if the patient does relapse at that time.
Thank you so much.
Abhishek?
So if immunotherapy is the future, as we can see, shouldn't every lymphoma at relapse be given an allogenic transplant, which we already have as a sort of immunotherapy, before the costly ones are used or are available across the world?
So
but
that's
we still do autologous.
So I love the provocative question. You and me are kindred spirits. You know, it's like we're got to push the envelope. However, I think immunotherapy is in part the future. I don't think it's all of it. We have to be a little bit careful. Sometimes when you go with the really cool, you may throw out the really effective. And in Hodgkin lymphoma, we actually have really good results that you've got a very high bar to overcome. So that's one thing to say. The second thing is, you're right, the most effective immunotherapy is an allogeneic transplant. However, the most toxic immunotherapy is an allogeneic transplant. So you have to go, okay, benefit and toxicity. You know, one of my colleagues sometimes jokes and says there are fates worse than death. Sometimes if you have been cured of your Hodgkin lymphoma, but are having an absolutely terrible time from your graft versus host disease, You are not smiling. This is not a good day for you. So that's the problem. So I hear you, but I think we've got work to do with less toxic treatment.
Thank you so much, Dr. Ansel. I think that's all what we could accommodate. Wonderful lecture. I mean, it was an eye-opener. Thank you so much for accepting the invitation and honoring us by your masterly presentation.
Thank you very much for having me.
Please. Bye-bye, sir.
Bye-bye.
I have a slide to introduce the next speaker. So we already have Dr. Luca who has logged in, and we are privileged to have his participation today as a speaker, guest speaker today. Dr. Luca Archeni is Professor, Department of Hematology at the University of Pavia School of Medicine, Pavia, Italy. And he is going to speak on a very focused subject of splenic marginal zone lymphoma to us. So over to you, sir.
Good afternoon. Thank you for the invitation. It's a great pleasure for me. Now I have to share the slides.
Yes, sir.
I am not able to do it. Can you help me?
Kalpesh, do you
Yeah,
have?
Professor Luca.
Yeah.
Yeah, are you able to find that share screen button on your screen at the bottom?
I have to share the screen, but
Okay.
I have to
You just
give the
click on it.
privacy.
You have to select your window and then share it.
I have an Apple computer.
Mm-hmm.
Can I send you my presentation?
Please do it here. Yeah, I'm just
Can you send me your
typing my email ID to you.
Okay. So again, thank you for the invitation. My topic is very peculiar because you asked me to talk about splenic marginal zone lymphoma. This is a quite rare disorder with very limited evidence-based data about treatment. And as you know, splenic marginal zone lymphoma is part of the group of marginal zone lymphoma and WHO classification recognize three entities. One is splenic, one is nodal, and the other one extranodal marginal zone lymphoma of Malt. But we can also have some cases that present with disseminated disease with nodal, extranodal, and splenic involvement. The marginal zone lymphoma are the third most common B-cell lymphoma, and is in the recent epidemiological paper we know that it's slightly inferior the prevalence of the all marginal zone lymphoma respect to the follicular one lymphomas. As I told you before, despite the classification, the WHO classification, we know very well in the clinical practice that sometimes we face some patients that have only a leukemic picture, so only bone marrow and blood involvement. And on the other side, in the opposite side of the spectrum, we have cases with disseminated disease, in which it's very difficult to say if I have in front of me the patient with splenic, with nodal, or with Malt lymphoma with disseminated phase. What about splenic marginal zone lymphoma? Splenic marginal zone lymphoma is a quite rare disorder. In the US, it has been demonstrated is around less than 1% of all lymphomas, and it's a disease of elderly people, and the median age at the diagnosis is around 70 years. It's a typical disease of white male of people with age of more than 70 years, and a recent epidemiological study demonstrated that some autoimmune condition, asthma, and the use of RDI are related to the development of this lymphoma. And in this study, hepatitis C is a bit less controversial. How to perform a diagnosis of splenic marginal zone lymphoma? As you know, the perfect diagnosis can be obtained by splenic histology, so through a splenectomy. But when we have no possibility, or we have no room to remove the spleen only for a diagnostic purpose, we will talk about the use of the splenectomy as a therapeutic approach. But for a diagnostic purpose, we can make diagnosis of splenic marginal zone lymphoma if we have a typical morphology in peripheral blood and in bone marrow, and a typical flow cytometry profile, and a presence of infiltrate of CD20 positive cells with intrasinusoidal pattern. I am not a pathologist, but I recall that spleen histology is characterized by small cells that surround the reactive germinal center in the white pulp, and the lymphoma can progress in the later phase of the development in the red pulp. But it's a disease that originates in the white pulp. Some interesting points from a histological point of view. I repeat, I underline that I am not a pathologist, but I can remember that we have some cases with a plasma-seq differentiation, and these are typically associated with autoimmune manifestation like autoimmune hemolytic anemia or immune thrombocytopenia. Sometimes the differential diagnosis with follicular lymphoma is quite difficult because in some cases we can have a follicular pattern. It's very important to remember that this lymphoma, like the other indolent lymphoma in the spectrum of indolent lymphoma, for low-grade lymphoma, can transform in a large B-cell lymphoma, in diffuse large B-cell lymphoma. So one indication to splenectomy is when you have a suspicion of transformation in the spleen, because only with the splenectomy you can be able to demonstrate the transformation of the lymphoma. Now, we talk about the typical approach in an outpatient department for a patient with splenic marginal zone lymphoma. Historically, we know that in the past, some of these cases have been classified as splenic lymphoma with villous lymphocytes because we have these bipolar villi in small lymphocytes circulating in the blood. However, at now, the presence of this cell is quite suggestive of this diagnosis, but are not sufficient to make diagnosis of splenic marginal zone lymphoma. The first approach is the flow cytometry. The flow cytometry in peripheral blood and in bone marrow is able to differentiate splenic marginal zone lymphoma by the other leukemic disease like CLL, very different pattern, mantle cell lymphoma with leukemic pattern, hairy cell leukemia, and hairy cell leukemia variant. But as you can see, splenic marginal zone lymphoma is generally expressing immunoglobulin, FMC7 strongly positive, sometimes is 11C negative, positive, but it's always CD103 and 123 negative, and sometimes can be CD25 positive, but not like hairy cell leukemia. CD200 can be useful to differentiate splenic marginal zone lymphoma with CLL and with hairy cell leukemia. After the flow cytometry from your lab, you can have the bone marrow picture. These are the bone marrow involvement is virtually present in 100% of the cases, and I have to underline, to stress very strongly that the morphology is not sufficient. You need to demonstrate with immunohistochemistry, also small infiltrates. I saw some patients with very limited infiltration of the lymphoma with huge splenomegaly, and you have to demonstrate the presence of CD20 positive, CD10 negative, and cyclin D1 negative cells. The intrasinusoidal infiltrate, when I talk about the criteria proposed by Matutes, I remember this is a typical, but I have to stress this is not pathognomonic for the disease. These are our series, not so recent, but at the end in the 2008, in 28 we published this series, and we demonstrate that the sinusoidal pattern was present as the only pattern, that's the single pattern only in 5% of the cases, and it was present with other patterns in around 3/4 of the cases. So no 100% of the cases present this sinusoidal pattern. The other approach is the immunohistochemistry. The immunohistochemistry profile of splenic marginal zone lymphoma mirrors the flow cytometry approach, and is able to give to the pathology a lot of information about the expression of other proteins that are not detected in flow cytometry. To be complete, I have also to remember that the WHO classification, the last update presented and reported to provisional entities that are not classified as a splenic marginal zone lymphoma, but are called splenic diffuse red pulp small B-cell lymphoma and hairy cell leukemia variant. And we will see in the next edition, in the next update of WHO classification, if this entity will become established entity, and the denomination of this entity maybe can change, especially the definition of hairy cell leukemia variant, because it's quite misleading, because it's a disease more similar to splenic lymphoma than to hairy cell leukemia. The WHO classification also considers some cases of splenic small B-cell lymphoma that do not fulfill the criteria for no established entity, no splenic marginal zone lymphoma, no splenic diffuse red pulp small B-cell lymphoma, no hairy cell leukemia variant. And this lymphoma should be diagnosed by your pathologist as splenic B-cell lymphoma leukemia unclassifiable. 2 words about the splenic diffuse red pulp small B-cell lymphoma. It's a very uncommon subtype of lymphoma. It's a rare presentation of a rare disease like splenic marginal zone lymphoma. As I told you before, splenic marginal zone lymphoma is a disease of the white pulp, while in this case, the red pulp is diffusely involved by neoplastic cells. In the seminal report by the French group, they reported around 40 cases. They were prevalently elderly men, and they presented with splenomegaly, with a lymphocytosis not so impressive like splenic marginal zone lymphoma. And it's interesting that only 12 of these patients have been splenectomized. So we define this patient like patient with red pulp lymphoma without examining the red pulp. But from a cytological point of view, some authors reported this entity also as splenic red pulp lymphoma with numerous basophilic villous lymphocyte. But I am quite reluctant to use a cytological approach in a nosologic definition of splenic lymphoma in 2021. What about hairy cell leukemia variant? Hairy cell leukemia variant that maybe will be called in a different way in the next WHO classification is a rare disorder. Is considered in the series of hairy cell around 10% of all hairy cells. The presentation is very similar to splenic marginal zone lymphoma because we have subjects with splenomegaly, lymphocytosis, and cytopenias. We have no decreased level of monocytes like in hairy cell leukemia. In these cases are generally 11C positive, 103 positive, and CD25 negative respect in comparison to hairy cell leukemia. And we have also some data from a molecular point of view because we have in majority of the cases the mutation of MAP2K1 gene encoding MEK1. And this is the differential diagnosis between hairy cell leukemia and hairy cell leukemia gavanta. I will not go in detail in this quite boring aspect, but I would like to stress that hairy cell leukemia variant is a disease very similar to splenic marginal zone lymphoma and to splenic red pulp lymphoma respect to hairy cell leukemia variant. Hairy cell leukemia classical one. As I told you before, in some cases, also S-square pathology can be not able to make a diagnosis, a definitive one, and so they need to make this diagnosis of splenic small B-cell lymphoma and not otherwise classified. Pay attention to the expression of CD5 because sometimes if I have a patient with CD5 positivity, I think this patient is not a splenic marginal zone lymphoma, maybe it's a mantle cell lymphoma. So look for the translocation, look for the expression of cyclin E1, and you can have this expression also in splenic marginal zone lymphoma. And the French authors consider these cases with more mutated for immunoglobulin with more marked lymphocytosis. After perform flow cytometry, and bone marrow histology, we need to study this patient from a cytogenetical and molecular point of view. And this is the most complete series of patients studied with cytogenetics, and the lesion 7q is present in 40% of the cases of splenic marginal zone lymphoma. We study in the last 10 years also the immunoglobulin, mirroring and looking at the findings that have been presented for CLL. We also were able, my group was able to demonstrate the stereotyped sequence of immunoglobulin gene in splenic marginal zone lymphoma. What about the molecular landscape of splenic marginal zone lymphoma? Is not so mutated like diffuse large B-cell lymphoma, but it's a bit higher mutated than CLL. This is one of the paper published with whole exome sequencing in splenic marginal zone lymphoma by my colleague Davide Rossi in Switzerland. These are the description of the gene that are mutated in splenic marginal zone lymphoma. Just to note that Notch2 is mutated in more than 20% of the cases, and the pathway that are involved are the Notch pathway and NF-kappa B and B-cell receptor pathway that are involved in marginal zone development. And this is the Notch2, that is the Notch pathway accounts for 1/3 of all the cases. and we look at the mutation of the gene involved in marginal zone development, we have around 60% of the splenic marginal zone lymphoma. Interestingly, Notch2 is highly mutated in splenic marginal zone lymphoma, while is negligibly mutated in other B-cell neoplasia. It is interesting about Notch2 that we also studied in diffuse large B-cell lymphoma associated with hepatitis C infection, and we see some cases of Notch2 mutation in diffuse large B-cell lymphoma with hepatitis C, because maybe these cases are marginal zone lymphoma that transform to diffuse large B-cell lymphoma. So this is cartoon summarizes the molecular, immunogenetic, and cytogenetic alteration of splenic marginal zone lymphoma. We can say that Notch signaling is mutating around 40%, and around 1/3 of the patient present stereobiased use of this immunoglobulin gene, that is the 1204, and around 1/3 of the cases present 7q deletion. What about the outcome of this patient? These are the series published in the literature in the last decades, and then you see that is an indolent disease with very high survival rate at 5 and 10 years. And these are our series from Italy that we published many years ago, more than 300 cases, and we were able to stratify this patient in 3 different outcome or risk categories. We based on these 3 simple parameters: hemoglobin, then 12 grams deciliter, LDH, and albumin low 3.5 gram deciliter. And you see here we have very indolent cases in the low risk categories, quite indolent cases intermediate risk, and a 25% of cases that are categorized as splenic marginal zone lymphoma, but are not so indolent disease in the survival core for lymphoma-specific survival. So we can say that splenic marginal zone lymphoma is a general indolent disease with a median survival around 10 years, but we have around 1/4 of patients that present a worse outcome. The prognostic assessment of splenic marginal zone lymphoma has been developed by the Spanish group with our help, and they were able to demonstrate the presence of 3 categories of prognosis, similar to our original paper, but the concept that I would like to stress, the message to take home, that in this indolent disease we have a subset of patients that are not so at good prognosis. Recently, a huge effort has been made by the International Extranodal Lymphoma Study Group, by the group of Davide Rossi, and international effort collecting more than 400 spleen samples. And this study has been recently accepted in Blood just a few days ago. And this is the curve of the survival of the patient collected in this huge series of splenic marginal zone lymphoma. You can see that with a median follow-up of more than 9 years, the median overall survival is higher than our series because it's 16.5 years. And these cases have been characterized by the molecular, immunogenetic, and cytogenetical point of view. I just like to show you that this study was able to demonstrate 3 different categories. One that is involving the Notch and NF-kappa B genes. The other is related to epigenetic gene, and the other one is related to TP50 and generally to the DNA damage genes. So we have the same disease, the same histology, but with 3 different molecular category. And this is interesting because the outcome of these cases is quite different, because in these cases we have this type of outcome, while in the damage the survival is lower, because when we have the TP50 mutation, the survival is lower, is 46% against 77%. This is a very difficult approach, I understand. So I show you before a very simple approach to make prognosis of splenic marginal zone lymphoma with hemoglobin, albumin, and so on. On the other side, I show you a very innovative and complex approach with a molecular stratification, but what we have also in the clinic, because the clinical factors are available at the onset of disease, at diagnosis, but in the follicular lymphoma, recently we have some data about the early progressor outcome of patients with follicular lymphoma. This is true also for marginal zone lymphoma, and to demonstrate that, we conducted a study, an international study based on our cooperative group that is called Fondazione Italiana Linfomi. We collected more than 1,300 patients with indolent lymphoma, and we extracted a subset of 321 patients with marginal zone lymphoma that have been treated. And this is the progression-free survival of this patient. I have to say that these are all marginal zone lymphoma, are not only splenic marginal zone lymphoma, but we focus our attention to the early progressor with POD24, and around 20% of these patients experience early progression within 2 years from the start of treatment. And you can see here the outcome, the overall survival, like in Casulo series in our marginal zone lymphoma that progress early is worse than the patient that do not progress in the first 2 years. And this is true for the extranodal marginal zone lymphoma, and that is also demonstrated and confirmed by the International Extranodal Lymphoma Study Group study by Conconi in blood, and by splenic marginal zone, also in a splenic marginal zone lymphoma. So we demonstrated with simple parameters many years ago that we have a 25% of patients that are not very good prognosis, and also in a dynamic way we have demonstrated that this 25% is similar to the follicular lymphoma setting. Another important event in splenic marginal zone lymphoma, I remember to you, is the transformation, and the cumulative incidence in marginal zone lymphoma in the Alderuccio study in JCO is around 7% at 5 years and 80% at 10 years. And this is the outcome of patient transformed and respect the patient not transformed. So collecting all the information that I give you about the diagnosis and the cytogenetical and flow cytometry, cytogenetical, histological, immunohistochemical approach in splenic marginal zone lymphoma, what to do in a patient with splenic marginal zone lymphoma, you need to make this is the ESMO guidelines. You need to have a panel that include CD20, CD10, CD5, CD23, cyclin D1 throughout mantle cell lymphoma, and you have also to need an expert hemopathologist, and also you need in splenic marginal zone lymphoma to assess for hepatitis C and hepatitis B infection. Very difficult and very, we can discuss later about the utility of PET in this patient because it's a very controversial issue. Now, how to treat a patient with splenic marginal zone lymphoma? As I told you at the beginning of my talk, we have no evidence-based data on splenic marginal zone lymphoma, so we have only retrospective series, and rituximab alone is the preferred initial therapy for splenic with marginal zone lymphoma, but we can also say that sometimes chemoimmunotherapy can be indicated, and also in some cases splenectomy. So I cannot give you a definite answer with these 3 options, but I will present you the data about these 3 different options. At the end of my talk, I will talk about the antiviral approach in this patient. So first of all, like in splenic marginal zone lymphoma, I have not, like in follicular lymphoma, I do not need to treat all the patients with the splenic marginal zone lymphoma, but I need to have the criteria to start the treatment. This criteria has been established by the ESMO guidelines and are progressive or painful splenomegaly, cytopenias due to progressive splenomegaly, and so we have to need anemia, thrombocytopenia, and neutropenia. And also I have to say that the guidelines suggest to treat hemolytic anemia and immune thrombocytopenia specifically treated for that and not directly for the lymphoma. Also, we have the different response criteria. I will not go in details in illustrating this criteria, but you know that this is a disease with a leukemic picture, with a bone marrow involvement, with a splenomegaly. So the complete response should be assessed if I have a resolution of splenomegaly, a resolution of cytopenias, as no evidence of circulating monoclonal B cells at the flow cytometry. And these are also the criteria that have been adopted in the few prospective trials that have been conducted in splenic marginal zone lymphoma. So, which is the outcome of patients that have been splenectomized? This is the series that we published at retrospective 1. As you see in this Kaplan-Meier, we can see that splenectomy seems to be go better than no splenectomy, but maybe in this situation we have a selection bias. In this case, we splenectomize patient younger with limited disease, with no comorbidities. On the other side, this elegant study by the French group demonstrated that the median PFS in patients that have been treated with splenectomy alone, we know other approach is around 8 years with histologic transformation in around 10%. These are the summary of the whole experience in splenectomy that I summarized in a review in Blood some years ago. Just to be very complete, I would like to remember to you, but we are all physicians, that splenectomy is not devoid of toxicity. Especially, we have to make attention not to the vascular complication and to the infection. And I would like to remember that in 2 recent series published from France and from British Columbia, 5% of the patient had infectious complication. What about rituximab? I told you many times that we have no prospective trial. We have very few prospective trial, and we have no randomized trial, so the evidence-based data are very scanty, but rituximab is the standard approach in splenic marginal zone lymphoma, and this is the most important series published by the Greek group. They also propose to make a maintenance treatment after the first line approach with rituximab alone. However, it has been studied also the combination with chemotherapy. Italy and France conducted 2 trials. One is the R-COMP, that is the combination of rituximab and COMP with Myoset and with liposomal anthracycline, because there were some pharmacokinetic data that suggested that this drug accumulates in the spleen. So a very good rate of complete response, a very good progression-free survival, not so better than splenectomy, but also some hematological toxicity and 2 deaths for infection. So maybe this approach can be not completely good for patients with splenic marginal zone lymphoma, that is a patient of elderly people and with a very delicate, fragile, and high risk of infection. The other study that's been conducted is the PRIMA study, because in this year we had a lot of data about the combination of rituximab and bendamustine in marginal zone lymphoma, and in this study, the overall response rate with rituximab bendamustine was 91%, so very impressive, with a 73% of complete remission. But we paid a lot of toxicity, in particular neutropenia in 43% of the cases, and also with infection and febrile neutropenia. These are the PFS with rituximab bendamustine and the overall survival. Maybe this is a good approach, but maybe it should be reserved to patients with more advanced disease and with patients with at younger age. Interesting, we are also able, the field, the Fondazione Italiana Lymphoma Group was able to demonstrate the capability of molecular response of rituximab bendamustine combination in splenic marginal zone lymphoma. But we talk a lot about very traditional, very old-fashioned approach in splenic marginal zone lymphoma, especially splenectomy. We talk about rituximab. This is not a new approach to splenic marginal zone lymphoma. We talk about chemotherapy, but what about the new approach in lymphomas, in indolent lymphomas? Is there room for other approach in splenic marginal zone lymphoma? We have some molecular hints that some drugs can be useful with respect to others in splenic marginal zone lymphoma, as I described before for splenic marginal zone lymphoma. Just a glimpse about the use of a new monoclonal antibody, not a very molecular or chemo-free approach, but you know very well that the Gallium study was conducted in follicular lymphoma and also in indolent and marginal zone lymphoma. These are the data about the marginal zone lymphoma, and this PFS is quite self-explicative because we have no difference of PFS with rituximab and with obinutuzumab. And this is also confirmed in PFS assessed by independent committee, the overall survival, and time to next treatment. And also, as you know, the combination of obinutuzumab bemda is characterized by important toxic, especially important infectious risk. What about the new drugs in splenic marginal zone lymphoma? These are the seminal paper of Fowler on rituximab and lenalidomide approach, and this is the PFS of patients treated with splenic marginal zone lymphoma. But I have to say that this case were not in this series we do not have splenic marginal zone lymphoma. We are waiting also for the data by the MAGNIFY study. The MAGNIFY study is an interesting study in the relapse refractory setting with follicular and marginal zone lymphoma that have been treated with rituximab, lenalidomide, R2 or R-square treatment, and then are randomized by rituximab, lenalidomide versus rituximab alone. We do not have the data about the two different approach, but just we have the data about the response to the induction phase, and we will look at the 16 cases of splenic marginal zone lymphoma. The median PFS is more than 3 years. The overall response rate is around 50%, with half of the patients that responds to rituximab and lenalidomide scheme. The other study that we have is the AUGMENT study. Also is a study in a relapse refractory setting that randomized rituximab and lenalidomide versus a very weak arm that is the rituximab plus placebo. But these are the curves that we have the superiority of R-square respect to rituximab alone. However, in the marginal zone setting, this approach is not able to be superior respect to rituximab alone, but we have to say that these are very few cases, and quite surprising, the FDA approved this combination for relapse refractory follicular, also marginal zone lymphoma. So in US, the combination is possible to use in marginal zone lymphoma. What about other drugs? One are the PI3K inhibitors, and the activity in marginal zone lymphoma of idelalisib is not negligible because we have 40% of PR and 7% of CR. However, it seems that the response in marginal zone lymphoma seems less impressive with respect to the follicular lymphoma. And this is the data about the marginal zone lymphoma, very few cases. I don't think that we have many splenic marginal zone lymphoma. We have also other compounds that are PI3K inhibitor, just a glimpse to the umbralisib because it's a very effective drug in marginal zone cohort. Zinzani presented not in the last Lugano meeting, but in the previous one, the data about umbralisib phase 2 study in relapsed and refractory marginal zone lymphoma, and is a PI3K delta isoform inhibitor, very less toxic. The toxicity profile is much better than the other compounds. The overall response rate is more than 50% with a CR rate of 12%. But we talk a lot about lenalidomide, we talk a lot about the PI3K inhibitors, but we have to say that the drug for marginal zone lymphoma, splenic marginal zone lymphoma that are relapsed or refractory is ibrutinib. This is the first trial published in literature about the activity of ibrutinib in relapsed refractory marginal zone lymphoma. We have 63 patients published by Noam Blythe in 2017. We have a small series of splenic marginal zone lymphoma. In this case, the overall response rate is 40% with 3% of CR and 45% of PR. And you can see here the response is quite better than overall response rate. Also in patients with less than PR, we have some activity of the drug, and the PFS is more than 1 year, is around 14 years. And in the standard follow-up of 33 months, the overall response rate is around 60%, and the PFS is higher, is around 16 months. And we will look at the splenic marginal zone lymphoma. The combination of the ibrutinib was able to obtain in relapsed refractory setting an overall response rate of 62%. I have no time to discuss about other compounds, but also to give you an info about the fact that an international effort has been made to study the ibrutinib combination with rituximab instead of rituximab and chlorambucil, the first-line approach of marginal zone lymphoma. Obviously, the International Extranodal Lymphoma Study Group focused on marginal zone lymphoma, but we have a small series of splenic marginal zone lymphoma. I think that is not 15 patients, but this series will be 30 patients between Italy and France and the other country participating to the study. So this is an ongoing study, and in the future we will have data about the activity of ibrutinib plus rituximab in a chemo-free approach for marginal zone lymphoma, and also in a splenic marginal zone lymphoma and in nodal marginal zone lymphoma. The last part of my talk is dedicated to a very particular, a very peculiar, very distinct aspect of splenic marginal zone lymphoma, that is the association with hepatitis C virus. It's a very intriguing issue because it's interesting from the lymphomagenesis of the marginal zone lymphoma, but also from a therapeutical point of view. And I'm going to show you this in the next few slides. Just to remember you that hepatitis C has been demonstrated by the epidemiological study that is associated with non-Hodgkin lymphomas. You know very well that marginal zone lymphoma is the typical histotype associated with hepatitis C infection, but also diffuse large B-cell lymphoma and lymphoplasmacytoid lymphoma in this pool case control study have been reported. But when we look in a registry, like in our region, in the northern Italy, in the region Lombardia, about the distribution of histology, we saw that in our 250 consecutive patients with lymphoma and hepatitis, the diffuse large B-cell lymphoma was the most frequent histotype. It is quite surprising. And also, we were able to demonstrate that extranodal lymphoma was quite frequent, and part of this patient have been recognized to have also the hepatitis C at the same time of the diagnosis of lymphoma. So around 1/3 of the patients are diagnosed with lymphoma and hepatitis in the same time. And as expected, the cryoglobulinemia and monoclonal component is associated with the detection of indolent time. This is a very interesting topic, the hepatitis C and lymphoma, because it is a multidisciplinary issue. I am a hematologist, but I have to discuss it with my infectious disease specialist, with rheumatologists, with internal medicine, with pathologists, with neurologists, and so on. And we perform a diagnostic guide. We propose diagnostic guideline for patients with hepatitis C-related extrahepatic manifestation. And regarding the lymphoma, we assessed that the first line, we have to make the diagnostic procedure, including virological and liver assessment. The other point is that if we suspect a lymphoma, histology is mandatory. And we have to remember also to our colleagues that are not hematologists that monocular B-cell lymphocytosis is not an overt lymphoma. So we need a lymph node, we need an extranodal tissue, we need a lymphoma diagnosis to say that it is a lymphoma. So what about the history of hepatitis C explaining marginal zone lymphoma? Because I told you that we have epidemiological study that demonstrate association with marginal zone lymphoma. But on the other side, we have many quite not recent report that splenic marginal zone lymphoma is quite typically hepatitis C infection. One is from Italy many years ago, and one is this study from French. This study from French is what is the second part is the update of the seminal paper by Olivier Hermine in New England Journal of Medicine, the activity of interferon plus minus ribavirin in splenic marginal zone lymphoma with hepatitis C infection. I have also to say that in some cases we have typical presentation of marginal zone lymphoma and hepatitis C infection. This is the so-called lymphoma-like marginal zone lymphoma. But we have to talk about splenic marginal zone lymphoma and not with marginal zone lymphoma at all. So just a brief memento. Another important message that I would like to give you, remember that hepatitis C virus is called hepatitis C by us, by researcher, but it's not only a lymphotropic virus. And it's quite typical that in patients with lymphoproliferation, the advanced liver disease is not so frequent, because in this case, the lymphoma, the virus is less hepatotropic and is more lymphotropic. These are our first study in the Fondazione Italiana Linfomia, our cooperative group, and we were able to demonstrate that the interferon approach in this patient was better than never antiviral treatment in this patient. And this is the meta-analysis made by a German colleague in all patients treated with marginal zone, with interferon and indolent lymphomas. And as you can see here, with interferon, the overall response rate is around 73%, and it's quite high, a bit higher in marginal zone lymphoma. And also the response is quite related, is higher in patients obtain and sustain virological response, so a clearance of the virus in the peripheral blood. However, in the last years, we do not use any more interferon. We use direct acting antivirals. And this is the first case reported in literature about a splenic marginal zone lymphoma treated in a prospective trial, in an investigational trial. This patient with a genotype 1b has been treated with antiviral treatment, no interferon, no antiproliferative activity or interferon. And as you can see here, the RNA decreased during the treatment, but also the spleen dimension and also the lymphocytosis, the clonal, the leukemic picture ameliorated during the treatment of with the direct agent. This is the retrospective study we conducted across Europe and US in the recent years. We collected 46 cases 37 marginal zone lymphoma and 17 splenic marginal zone lymphoma. Overall response rate is 76%. Complete response is less impressive with respect to interferon, but these are patients that are treated not conventionally, only with direct agent. As you can see here, we have also splenic marginal zone lymphoma, and this is the lymphoma response of this patient. And if we look at the response of splenic, we see that the complete response are not so high, and we will see the same in the next slide when we present our prospective trial. So the splenic marginal zone lymphoma that appeared at the beginning of the first lymphoma that responded to antiviral treatment, it seemed not so responsive, or better to say, it's less responsive than other subtype. Well, what I can say for sure is that CLL is not hepatitis C dependent. Also, the hepatitis C positive cases, despite quite rare, do not respond to antiviral treatment. And these are the progression-free survival. This patient treated with direct agent without any conventional treatment, and the 2-year progression-free survival is 65%. And some CR and PR are the duration of the response is quite impressive. If we compare the interferon era with the interferon-free era, so the first study by Fondazione Italiana Linfomi with the second one, you can say that the overall response rate is not so different, higher in the first experience, but as I told you before, the CR rate is less with the direct agent respect to the interferon. All this data, this amount of data, brings the National Comprehensive Cancer Network guidelines, the ESMO guidelines, also the new ones, and the internal medicine guidelines and multidisciplinary guidelines to recommend the use of antiviral treatment in patients not needing a mediated conventional approach. After that, this study, we recently reported at the Lugano meeting the final result of this multi-center study to evaluate the antiviral activity of interferon-free treatment in hepatitis C virus-associated indolent lymphomas. Just a few slides. One is the types of the histotypes. We described prospectively 40 patients. 6 are splenic marginal zone lymphoma, 7 are nodal, and 14 are extranodal. We have 2 small lymphocytic, 6 lymphoplasmocytic, 1 follicular, and CD5 negative B-cell lymphoma not otherwise specified. And these are lymphoma that Michele Merli presented at the last meeting, just to look at the splenic marginal zone lymphoma. As you can see here, it's quite unexpected that the splenic marginal zone lymphoma is not so responsive, while is quite responsive the extranodal marginal zone lymphoma. And in nodal marginal zone, in the multi-lymphoma, the response is around 71%. This is the PFS. PFS is projected at 3 years around 80%. And all patients are alive. The median PFS is not reached. As I told you, the PFS at 3 years projected is 80%. And we have 9 progression, 6 at the stage after direct agent, and 3 during the follow-up. Only 1 patient in stable disease progressed after antiviral treatment. At now, we did not observe any histological transformation. This is the PFS for all the cases. The outcome is not different from between marginal zone and non-marginal zone histotype. And these are very few cases, but splenic marginal zone lymphoma presented a 3-year progression-free survival of 67% at 3 years. And this is the duration response. You remember the first slide I show you about the retrospective series. Is quite similar. We have some cases that have a quite long durational response after 2 years, and some of them after 3 years, with a median time in stable CR of 23 months. So these are patients that are treated only with antiviral treatment, and after 23 years, more or less 2 years, are not treated with conventional, have been not treated with conventional treatment. This is my last slide. I came from Pavia, that is the city of many important doctors in the past. Maybe you know the triangle of Scarpa, and this is the anatomical theater. Thank you for your attention, and thank you for having me.
Thank you so much, sir, for the detailed talk on splenic marginal zone lymphoma. We enjoyed it. It was a complete talk. We have some of our delegates who may like to ask you some question. So Dr. Sweta, unmute yourself.
So I had a doubt, the risk stratification that we use to for these splenic marginal zone lymphoma, can we also use the same to decide which treatment will be better for our patients, like just rituximab or splenectomy or BR and so on?
That's a very good question. I have to be honest that the score has been built not to decide a treatment. However, in the clinical practice, we use generally rituximab monotherapy for patients not with advanced disease, so with no nodal disease, and with no extranodal localization, with important leukemic presentation. And if I calculate the score of this patient, if I calculate this patient is generally in the low intermediate category. However, the patient with very bad risk disease, the first thing before start treatment is to rule out the transformation of the patient. I had no time, maybe I have been a bit long in my presentation, but I suggest to perform PET in this patient if you have suspicion of transformation, because if you have suspicion, maybe systemic symptom, very high level of LDH, you have to perform a PET. PET, maybe you have focal hyper caption of the medium, and then you can perform splenectomy to roll out histology. In this case, these patients are high risk, but you need to perform R-CHOP. What about Arbenda? Well, I am a bit reluctant to use Arbenda in my patient because also before the COVID pandemic, because these are fragile patients, also the young one, the risk of infection is quite high. So I prefer rituximab coupled with CVP, very simple one, very old-fashioned approach. And because if you decide to use Benda, maybe because you have no alopecia or maybe for other reason, maybe it's better not to go too far. Maybe 4 cycles is enough. And as you look at our study, Arbenda and R-COMP, 3/4 of these patients were intermediate high risk.
Thank you, sir. Thank you so much. Very interesting.
One more question, Dr. Nidhi. Unmute yourself. We can't hear you.
So can you hear me now?
Yes.
Yeah. So my question is regarding the presentation in cases of diffuse red pulp lymphoma or the splenic lymphoma unclassifiable. As we know, SMZL will have 100% marrow involvement. Is it possible that this diffuse red pulp lymphoma or the other splenic lymphomas can just present with splenomegaly without any involvement of the bone marrow? Like sometimes we have patients presenting just with massive splenomegaly, but the marrow is normal after we exclude all other causes of splenomegaly.
Well, I told you that virtually 100% of the patients with splenic marginal zone lymphoma present bone marrow involvement. And retrospectively evaluating all the series from my center, also in cases in which a routine bone marrow and in routine flow did not detect bone marrow involvement, if we go deeper with immunoglobulin, heavy chain rearrangement, and so on, we found bone marrow involvement. So I think that the disease is a disease of bone marrow and the peripheral blood, and then of the spleen. I have also another quite provocative point. When we looked, we never published this data, but it's quite interesting. When we looked at the liver biopsy in patient splenectomies, an unexpected number of patients presented also liver involvement without hepatitis C, without transaminases elevation. So the question is, which is the origin of disease? I don't know. But I can say that I think that 100% of the cases present bone marrow involvement.
Thank you, sir. So that was a fantastic talk. Our knowledge of SMZL has significantly increased. We are grateful to you for having accepted this invitation and made us wiser. Thank you. Thank you, sir.
Thank you. And thank you for having me. Have a good night. Bye-bye.
Bye-bye. Now it's time to introduce our third speaker. And, she has been with us in past in Mumbai. She has also given certain webinars to us. I'm extremely grateful to her for having again accepted this invitation to speak to us. That is Dr. Lena Speck. She's Professor of Oncology, Department of Oncology at University of Copenhagen, Rigs Hospital, Denmark. And she's going to speak to us on primary extranodal lymphomas. So over to you, ma'am.
Thank you very much. I just need to know which screen I should share. Can you which screen can you see now? Can you see my screen?
Not yet.
Am I going to do something?
Kalpesh, can you guide her?
Dr. Lena, you have to share it.
Pardon?
You have to share your screen first. Are you able to see that share screen button at down on your Zoom screen? Or else we are having your presentation. If you don't mind, can we load it?
Pardon?
Can we load your slide?
Do you want
my slide is already loaded on my screen here. I just need to find the button with the share screen, and I don't know why it isn't there. I normally have it. Perhaps I should just.
It should be on your Zoom screen.
Finishes and then. Oh, how annoying! Where is it? Shall I enter again? Do you think? I can't see my Zoom screen.
Are you using the two screens, two monitors?
Yeah, I have two screens, but I can't see my my Zoom screen. I must be on Zoom, but I can't see the buttons for the Zoom. So why is that? That is very strange.
It should be there at the bottom.
I think I am finding it now, and I share my screen. And which screen do I want to share? I want to share this one. And can you see my screen now?
Yeah, we can see them. Yeah,
yes.
Make it full screen, ma'am.
I'll just make a slideshow.
Yeah.
So what are you seeing now? Are you seeing two images with my?
Yes. You have to stop your presentation.
I'd like to swap the screens, so I just need to find out where I do that.
You just click on the three dots at the bottom.
On the three dots, okay.
Yeah. And hide presentation, presenter view. Hide presenter view.
Yeah, but you need to see my other screen, don't you?
You can just make slideshow. That's it.
Yeah.
I can probably
slideshow.
Just click on the slideshow.
Can you see my can you see my slideshow now? Can you see my slide now?
You can see your slide.
Yeah, but you see, I have the slide on my other screen.
We can see your slide. You have to just make it slideshow. That's all.
Yeah, but it is slideshow on my other screen. That's the problem.
Okay.
So I need to swap the screens. And,
yes.
And that is something
Please
you do somewhere. I can't find the button where I swap the screens. Started.
Yes.
Thank you very much for the invitation. It would be nice when this COVID crisis is over and we can actually see each other again. But as far as that goes, it's nice that we can at least talk. And I'm going to talk about primary extranodal lymphomas. And thank you for the introduction. And how can I manage this one? Yeah, these are my disclosures. Now, primary extranodal lymphomas are defined as lymphomas which have a presenting lesion which is extranodal, and the extranodal lesion should constitute the predominant disease bulk. Although Walder's ring and the thymus and Pyer patches are excluded from the original Ann Arbor classification of extranodal disease, lymphomas in these sites are actually usually included. And the term is really only meaningful for stage 1 or 2 disease, whereas extranodal involvement as part of disseminated lymphoma is not included. Primary extranodal lymphomas are special. They may arise in any organ outside the lymph nodes, but the histopathological lymphoma subtypes occur in distinct patterns in different extranodal sites. So the marginal lymphomas are most common in the stomach, the T-cell lymphomas are most common in the skin, the diffuse large B-cell lymphomas are most common in the tonsils, and the NKT cell lymphomas are most common in the nose and paranasal sinuses. And they are special. The particular site of extranodal involvement may be associated with the etiology, so gastric lymphomas are associated with H. pylori infection, and salivary gland lymphomas with Sjögren's syndrome, and thyroid lymphomas with Hashimoto thyroiditis, of course. But the particular site of extranodal involvement is also important for prognosis and for management, independent of the importance of the histologic subtypes. So a diffuse large B-cell lymphoma in the brain has a long-term survival of less than 25%, whereas a diffuse large B-cell lymphoma in the tonsil has a long-term survival of 80 to 90%, and a diffuse large B-cell lymphoma in the testis has a long-term survival of 40 to 50%. So quite marked differences. And the treatment of primary extranodal lymphomas should then take into account the histopathologic type, the anatomic extent of disease as usual, but also the specific extranodal involvement. Now, the treatment of primary extranodal lymphomas, as always, should ideally be based on randomized trials, but even fewer exist than for nodal lymphomas, and nearly all studies with reasonable follow-up were carried out in the pre-rituximab era, which is so important for B-cell lymphomas. So our treatment of these lymphomas is generally based on retrospective series or phase 2 studies. And for the rarer extranodal presentations, we even do not have any large patient materials, so we have to extrapolate from the most similar cases that we find with other subtypes. The treatment of the primary external lymphomas is quite heavily on radiation therapy. Radiation therapy remains the most active single modality in the treatment of most types of lymphoma with regard to local control. And so it's an important part of the treatment of localized external lymphomas. The primary external lymphomas occur, they constitute about half of all localized lymphomas, that is all stage 1 and 2 lymphomas. And they constitute about 20 to 25% of all non-Hodgkin lymphomas. So they are actually a big group of lymphomas, but they are very diverse. They can arise in any organ. The most common sites are the gastrointestinal tract, the skin, the Waldeye's ring, the central nervous system, salivary glands, ocular adnexae, but you can find them in any organ you can think of. First of all, I'd like to talk about extranodal marginal zone B-cell lymphomas or mold lymphomas, mucosa-associated lymphoid tissue lymphomas. They are indolent lymphomas. 80% of them are stage 1E or 2E at diagnosis. They are often preceded by chronic inflammatory or autoimmune disorders, as mentioned previously. And they have a very indolent course with a 5-year survival of 95%, and that includes all stages. So this is really, for practical purposes, not a disease you die from. So here it's important not to overtreat patients, and local non-mutilating treatment is indicated in most cases, usually involves site radiotherapy. They are most commonly seen in the gastrointestinal tract. 45% of them are located in the GI tract, and by the large majority in the stomach, but they can also be found in the rest of the GI tract. But the remaining 55% are non-GI, and you can see them in the quite commonly in the eye or the eye adnexa, the lung, skin, salivary glands, female breast, and etc., but you can see them everywhere. And they are, in many locations, more or less clearly associated with sustained immune stimulation from chronic infection or autoimmune disorders. The stomach, of course, the Helicobacter pylori is very certain, and eradication should be attempted in all Helicobacter pylori positive cases. In the eye, in some, or the adnexa, in some geographical localizations, they seem to be associated with Chlamydia psittaci infection. And if that microorganism is demonstrated, then doxycycline can be a treatment, but we rarely see them in my part of the world. It's usually in Italy, actually. In the small intestine and Campylobacter, in skin, sometimes Borrelia, and so on and so forth. It's quite interesting. Quite a number of localizations have been associated with hepatitis C virus, and if that is demonstrated, antiviral treatment can be indicated. Now, mold lymphomas are in general treated with involved site radiation therapy if they're localized. And we know from the large randomized trials of the British group that 24 gray results in local control rates over 95%, and there is no indication that you need to go any higher. That was a large randomized study published by Laurie et al. some years ago. More recently, the FORT trial has been published, and just this year in Lancet Oncology, Peter Hoskin published the update of the study randomizing between 4 gray and 24 gray. And what they could demonstrate was that, and that is also shown in the most recent follow-up, is that 4 gray is inferior to 24 gray. So if you want to be most certain about achieving a local control, you should use 24 gray. But on the other hand, 4 gray is not a bad treatment. You achieve local control rates over 80%. And in these very indolent lymphomas, this may actually be a very good alternative, especially in older patients, because it is a very short treatment. It has hardly, in fact, no side effects. So the patients are really sometimes very well served with this, even in localized disease. And a new strategy is now emerging, which we use in my center and Memorial Sloan Kettering in the US, and many centers are actually doing this now, is to give these patients with localized mold lymphoma, and if there's no sort of threatening aspects of the disease, just give 4 gray, wait for 2 to 3 months, evaluate the patient, If the patient has achieved a complete remission, then no further treatment. If the patient has achieved a good partial remission, observe another 2 to 3 months and see some of them respond fairly slowly, and you may end up with a complete remission. But if there's an unsatisfactory response, then you can just, without any problems, give the 24 gray that you would have given initially if you had used the standard treatment. In this way, we're actually sparing 80% of the patients more than the 4 gray treatment, which is a very, very mild treatment, and that, of course, has made this treatment extremely popular. In the ILROC group, we are now starting a randomized trial, randomizing between the 4 gray and those two different strategies. Now, the homing properties of the mortal lymphoma cells has a consequence that we very often find multiple small lymphoma foci in affected organs, and hence the whole organ is in general the target for the radiotherapy. And the largest risk for these patients is, in fact, that they will relapse in the contralateral paired organ. If one breast or one salivary gland is affected, then there's a risk of 10 to 15% that the patient will have a relapse in the contralateral organ. And that, of course, may be successfully irradiated. The 5-year disease-free survival is 75% in mortal lymphomas in general. Some of them, like the gastric and the thyroid, for them is nearly 100%. Other sides, it may be slightly lower. This is a series of patients treated at Memorial Sloan Kettering some years ago. So they were treated with 30 gray for early stage mortal lymphoma. And as you can see, this is overall survival, including all causes of death. And you can see that in 15 years, it is coming down to 60%. But you can see over here that the probability of a cause-specific death, that is a death from lymphoma, is very, very small. These patients are often elderly, so obviously in 15 years observation time, some of them would die from other causes. The actual risk of dying from the disease is very, very small. And here they divided that data material into different organs of origin, and you can see the stomach cases seem to fare better. The head and neck, for instance, a little bit lower, but still 15 years follow-up and somewhat older elderly patients. This you can see is the probability of an infield failure, which is really very, very rare. So if they relapse after radiotherapy, it will usually be somewhere else in the body. The gastric mortal lymphomas are associated in 90% of cases with H. pylori gastritis, and in those cases, eradication will result in regression of the lymphoma in 70% of patients. So this is always the first trial of treatment if the patient has H. pylori in the biopsies. And the median time to histological response is about 5 months, so you need to be patient. And PCR evidence of monoclonality may persist in 50 to 75% of the patients. This is not an indication for further treatment. The relapse rate is 15% in 2 years. So you need to follow up these patients with endoscopic examinations with multiple biopsies to be sure that you find a relapse. There are then some patients who are predicted not to respond to H. pylori eradication. First of all, of course, the H. pylori negative patients. Then if there's invasion beyond the submucosa, evaluated by endoscopic ultrasound, which is an excellent examination for the gastric wall. And then in cases where you can show the T1118 translocation, which is present in up to 40% of cases, varying from different from patient material to patient material, or with BCLT10 mutation. And in these patients, involved site radiation therapy is indicated, and also, of course, for patients who are relapsing after H. pylori eradication. This is a large cohort of patients we gathered in the International Extranodal Lymphoma group. Andrew Worth was the primary investigator. And as you can see, in this large multinational cohort of gastric mortal lymphomas, you can see that the proportion of the failure-free survival is extremely high after 20 years. So it is a very indolent disease, and you should not overtreat it. We treated with involved site radiotherapy, that is the whole stomach and the perigastric lymph nodes with highly conformal modern techniques, as you can see here, only irradiating the target to the full dose, whereas there's only a very small dose to any other parts of the abdomen. What we do now is that we have examined the use of deep inspiration breath hold. You don't perhaps realize this, but the stomach is lying right beneath the heart. And so the left ventricle is in fact often lying just above the fundus of the stomach. And here you can see the treatment in free breathing, where you can see that the lower part of the heart actually gets some dose, even some of it perhaps in the high dose area. But if the patient breathes in deeply, then all the organs of the abdomen move accordingly, and the heart also somewhat changes shape. So what happens is that very often the whole of the heart can be kept completely out of the radiated volume, and also, of course, the lower aspects of the lung. So we're now doing this as a standard for our patients with gastric mortal lymphomas. By doing this, we can reduce the risk to the heart. Here you can see what we call a dose volume histogram with the heart dose in free breathing, and you can see it's much lower in deep inspiration breath hold. In fact, we were able to reduce the mean heart dose to 4.5 gray, which was in free breathing, down to 0.9 gray in deep inspiration breath hold. So that's nice. Non-gastric mortal lymphomas, again, the preferred treatment for the localized cases are involved site radiotherapy. 24 gray must still be quoted as the standard dose, but in fact, in many of these localizations, what I do is I give them 4 gray, wait and see. Many of them, for many of them, that is actually enough. It's important to use 3D dose planning for optimal technique and normal tissue sparing. And for special localizations, we have special technique, for instance, for sparing of the lens in the eye and so on. And as mentioned previously, special attention needs to be paid to paired organs at initial evaluation and also at follow-up, because of the homing properties of the lymphocytes. That is where the recurrences are most usually seen. This is just an example of a special technique used for isolated conjunctival mortal lymphoma. Very typical presentation with this salmon-colored infiltration in the conjunctiva. And we treat that with anterior electron field. And we use this lens-sparing device, which is the plastic haptic lens with a lead cylinder mounted, which is placed in the eye every time patient is treated. And by doing this, we are able to avoid cataracts in most patients. This is another case with a stage 1E pulmonary mortal lymphoma treated with involved site radiotherapy. You can see this highly conformal treatment, which only gives the full dose to the actual target, to the tumor, with a small margin. And we do again in deep inspiration breath hold so that we inflate the lungs and take most of the healthy lung away from the irradiated volume. Now, these were the indolent lymphomas. Then mantle cell lymphoma is somewhat more aggressive, obviously. And they are usually widely disseminated at diagnosis, but there are, in fact, around 10% of them that are in early stage of diagnosis. And they often involve the Waldeyer ring or the extraocular ocular orbital structures. Mantle cell lymphomas are very, very radiosensitive, and they are actually curable with local radiotherapy to 24 gray. Often, and I also do that, give brief immunochemotherapy with R-CHOP, but probably the radiation therapy is the most important part of the treatment. And most patients become long-term survivors, unlike, of course, patients with disseminated disease. It must also be said that the mantle cell lymphomas that are localized at diagnosis are usually of the more indolent histologic kind as well. It's not just the treatment, it's also the biology of the disease that gives the good prognosis. This is a report of a series of patients with limited stage mantle cell lymphoma from Vancouver. And they simply divided, it was not a randomized trial, but they divided them between the ones who did and the ones who did not have radiation therapy. And you can see the results were much better for those who had radiation therapy, both with regard to cumulative with regards to progression-free survival and overall survival. So in localized cases, it is important to remember that these patients should also have radiation therapy. This is one of our cases. mantle cell lymphoma in the right tonsil. The red volume is before and the pink after. There was not much difference before and after chemotherapy. And then we gave highly conformal radiotherapy, just giving the dose to the tonsil, and the patient became long-term survivor. Then we'll go to diffuse large B-cell lymphoma, which is, of course, an aggressive lymphoma. Around 40% of diffuse large B-cell lymphoma are localized at diagnosis, and about half of them are primary extranodal. And the treatment in an aggressive lymphoma is, of course, to start out with systemic treatment with rituximab and chemo and some typically CHOP. A brief course of that, and if the patient has a presentation with a high risk of CNS recurrence, then additional methotrexate is given. We give high dose intravenous methotrexate to be as certain as possible that we have good penetration into the whole of the CNS. And then we'll generally follow with involved site radiotherapy to 30 gray if the patient has achieved complete remission after chemotherapy, 40 gray if there is still residual disease. And these patients have actually a very good prognosis with 80% long-term survival. And here you can see a case of a diffuse large B-cell lymphoma located in the left maxillary sinus with the destruction of the walls. This is before chemotherapy. This is after chemotherapy, showing excellent shrinkage during chemotherapy. And down here you can see the treatment fields that the treatment that the patient had. Again, highly conformal modern radiation therapy, only irradiating what is strictly necessary. Now, when we are talking about diffuse large B-cell lymphoma and localized disease, I don't think we can avoid discussing the hot issue, which has been debated for several years and which is always comes up, namely, is radiation therapy at all necessary? And there are a couple of studies from recent years that have been debated a lot. And I'd like to just briefly go through the scene from my perspective. This is the Lamy study, which was published in 2018 for the LISA group, the French radiation therapy, the French lymphoma group. And it tested R-CHOP14 with or without radiotherapy in non-bulky, limited stage diffuse large B-cell lymphoma, and demonstrated that, or as it was said, that there was no difference. Now, there are some problems with this study, and I'd like to just draw your attention to that. First of all, 19% of the patients had a complete resection of their tumor already at initial surgery and were PET negative at the outset, and 5% did not receive the radiotherapy that they were randomized to. So in fact, 25% of all patients enrolled in this trial would not even be expected to have any benefit from radiation therapy and would therefore not contribute to the examination of the question of the role of radiation therapy. And also, the patterns of relapse study showed that in the R-CHOP alone arm, 13 patients relapsed. You can see the excellent prognosis, but 13 relapsed, and 5 of them at the initial site. Whereas in the combined modality arm, 10 patients relapsed, but never in the irradiated site. And if you look at the cumulative incidence curves of relapse here, you can see that the red one is chemo alone, and the dotted one is the combined modality treatment. And as you can see, it does, radiation therapy is clearly working, but the trial is not powered to detect a difference which is so small. But then you have to accept that differences will be very small in these patients because they have such a good prognosis, whatever you do with them. But another really important point is a bit more tricky here, but the statistical analysis of this trial was really not appropriate. They defined a margin of non-inferiority of 88% or less, and they reported 5-year event-free survival rates of 89% in the R-CHOP arm and 92% in the combined modality arm. So a 3% absolute difference. But then with the confidence interval that they indicate themselves in the trial, in the publication, the confidence interval went from minus 8.3 to plus 2.3, meaning that the 8% difference was actually within the confidence interval. So the correct statistical conclusion of this study is that the study outcome is inconclusive, and that non-inferiority has not been demonstrated. So it is actually how it should be interpreted correctly statistically. A more recent trial was the FLYER trial, which actually didn't test a radiotherapy at all. None of the patients got radiotherapy. So this is one of the points that it is used as an argument for missing radiotherapy, but it didn't actually examine this. It examined 6 cycles of R-CHOP versus 4 cycles and demonstrated no difference between those two treatments. And of course, less toxicity in the 4 cycles arm, so that was obvious. And then it has been used to demonstrate that radiation therapy was not necessary, because the trial demonstrated that 4 cycles of R-CHOP was about as good as 6 cycles of R-CHOP. And then we think we know that 6 cycles of R-CHOP is about as good as 3 to 4 cycles of R-CHOP plus radiation therapy. In fact, most of the trials had only 3 cycles of R-CHOP. And so by implication, it is concluded that 4 cycles of R-CHOP is about as good as 3 to 4 cycles of R-CHOP plus radiation therapy. But the question is this a fair interpretation? Because this is not a direct comparison. There was no trial, there was no arm testing radiation therapy. So it really is poor science. What we should do was to do a trial of 3 to 4 cycles of R-CHOP with or without involved site radiotherapy, but that trial has not been done. We must remember that the expected benefit of radiation therapy may be small. For instance, the 3% difference we saw in the NAMI trial was probably quite realistic. And that is as far as it goes when the underlying prognosis is so good. But the question here is, what side effects are we trying to avoid? Because they're likely to be very modest with just 30 gray or 30 gray involved site radiotherapy, which we would use for aggressive lymphomas for the majority of patients in this group. Also because diffuse large B-cell lymphoma, and particularly the extra nodal ones, are usually located in an area where the toxicity is very minor and the size of the lymphoma is pretty small. The really critical areas where we want to see if we can avoid radiation therapy, like in the mediastinum, are very rarely, as an area very rarely involved in diffuse large B-cell lymphoma. So my interpretation of the FLYER trial is that for these low-risk patients, the outcome is likely to be good regardless of approach. But you should still consider radiation therapy after 3 cycles of R-CHOP, actually, to optimize the local control, because even if there's only a 3% benefit, we do not want these patients to relapse. They are usually elderly and they will not tolerate relapse treatment very well, especially if the disease is slightly large, although not bulky, because then it would be low-risk patients. But we must remember that the late effects of radiotherapy in these patients, first of all, with the very small radiation volume, it is small, but it's also very unlikely to be problematic. In particular, the feared secondary cancers, you don't see them in patients over the age of 40 to 50 when they are irradiated. And the radiation therapy could be given alongside the extra rituximab, so that would even not prolong the treatment. And it must also be remembered that chemotherapy has also serious long-term consequences. This is a large population of patients from the SEER database, so not randomized. It's a large population-based registry where they looked at, Pew et al. Looked at the cardiac-specific mortality in patients with early-stage diffuse large B-cell lymphoma treated with and without radiation. And what they could demonstrate was that the patients who were treated without radiation therapy had a significantly higher risk of cardiac-specific mortality than the patients who were treated with combined modality, likely due to the higher cumulative doses of anthracyclines that the patients who did not have radiotherapy had received. And again, it must be remembered that many of these patients are older, and that older patients with diffuse large B-cell lymphoma are better treated with less immunochemotherapy and given radiation therapy instead, because they have a higher chemotoxicity, more infections, hospitalizations, more cardiac risk, more neurological damage, and as mentioned previously, it is less relevant with the long-term concerns of radiation therapy. And if we have just slightly lower local control, then these patients will be subjected to salvage, but then they do not have good salvage options. Most of these patients, elderly patients, will not tolerate intensive relapse treatment. And I just want to draw your attention to the cardiac problem with the anthracyclines. This is a study we did some years ago where we looked at all the randomized trials in Hodgkin's disease ever made by the EOCC and LISA groups. It was 9 trials containing more than 6,000 patients, and we were able to have both the heart dose and of radiation and the cumulative dose of anthracyclines. And as you can see from the multivariate analysis up here, the factors that had significant influence on the risk of cardiac events were mean dose to the heart of radiation and the cumulative dose of anthracyclines. And for both of these, both the mean heart dose and the cumulative dose of anthracyclines, there was an almost straight line relationship between the dose and the risk. And what you can see also here is that the increase in an increase in mean heart dose of 5 gray yields about the same excess risk of cardiac events as an increase in the cumulative anthracycline dose of about 50 milligrams per meter square. And 50 milligrams per meter square is what you get with 1 cycle of ABD or 1 cycle of CHOP. So if you try to avoid radiating the patient or the heart in a patient, that is only relevant, of course, if the heart is near the lymphoma. But then by omitting radiotherapy and instead giving more chemotherapy, you may in fact end up not protecting the heart, but actually giving the patient a higher risk of cardiac events later on if you give more cycles of chemotherapy. So that's just a warning. I think it's really important that we do these quantitative estimates and remember that chemotherapy is not a free ride either. Then I'll talk about another localized extranodal lymphoma, which we don't see very often. I don't know whether you see it a little bit more often in your area, but otherwise it is in the Far East. They have a high incidence of NK T-cell lymphoma, nasal type. They are usually located in the nose or the paranasal sinuses, and they are special. They're resistant to the usual anthracycline chemotherapy. They have the multi-drug resistance phenotype, but L-asparagine containing regimens have been shown to be significantly better. And for instance, the SMILE regimen, which we use, but there are other regimens as well, are more effective than ordinary CHOP in these patients. But the regimen is not as effective as the chemotherapy in B-cell lymphomas. In fact, the 5-year survival of patients with advanced disease is still less than 30% with these regimens. Radiation therapy is an essential component of the treatment of early stage disease because it's the only, by far the best modality to achieve local control. And in these lymphomas, you need to go higher in doses than normal. You need to go to at least 50 gray when you combine with the chemotherapy, even higher boost if you do it alone. I always give combined modality treatment. I don't trust that just radiation therapy, but that's probably because we find these cases when they are pretty advanced. The risk factors for these patients in early stage are age over 60, performance status 2 or above, stage 2, that is more than one region involved, elevated LDH, and importantly, invasion of neighboring structures. These tumors are highly aggressive and very invasive, and they arise usually in the nose, as you can see here, but they tend to invade the surrounding structures. They invade downwards into the mouth, laterally into the maxillary sinus or the ethmoid sinuses, and also into the orbit, superiorly into the brain, and medially into the other side of the nose, and possibly also to the other side of the paranasal sinuses. And it's really hard to see on imaging how far they stretch because they spread in the mucosa. So for these patients, because the chemotherapy is not highly effective, even if they get combined modality, we need to irradiate also the areas where there may well be microscopic disease. So they are pretty large, these irradiated volumes, as you can see defined over here. And this is quite a tough treatment, I must say. Now, do I have time to talk a little bit about primary cutaneous lymphomas? I hope I do.
Yes, yes.
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 Okay, fine. Because I've skipped the CNS lymphomas because they are so special that I wouldn't find time for them. But the primary cutaneous lymphomas are also very special, and I would like to talk about them because I think it's really important. They are a very heterogeneous group of T and B cell lymphomas. They're actually the second most common extranodal location of lymphomas after the GI tract. And they are most often T cell lymphomas as opposed to all the other locations of non-Hodgkin lymphomas where B cell lymphomas are more common in the adults. And what is important to know about cutaneous lymphomas is that their natural history is often much more indolent than that of nodal lymphomas of the same histologic subtype. So the most important thing to remember is do not overtreat. They should not be treated as aggressively as the same histologic subtype in other locations. They are very often solitary or localized skin lesions, and they are treated with local treatment. They can be simply removed surgically or most often treated with involved field radiotherapy, and you achieve long-term local control rates generally in about 80 to 100% of cases. And in recognition of this special way of behaving, the most recent WHO EOTC classification of lymphomas has actually defined the primary cutaneous lymphomas as a special groups. They are separated from the other lymphomas in recognition of the fact that they behave very differently and should be treated differently. The primary cutaneous B-cell lymphomas are the least common ones, and I guess they are less common in your part of the world than in Europe and North America. The most common ones are these three: the primary cutaneous marginal zone lymphomas, the primary cutaneous follicular center lymphomas, which are very, very indolent and should only be treated with very mild local treatment, and then the primary cutaneous diffuse large B-cell lymphoma leg type. And it needs this suffix leg type because it has special histologic characteristics. And if and you need your pathologist to actually be aware of this, because if it doesn't have that special those special characteristics, it is simply a follicular center lymphoma. It should be treated differently. But the leg type primary cutaneous diffuse large B-cell lymphomas are aggressive and should be treated. In fact, the only ones that should be treated up front with systemic treatments. And here you can see such a typical case of a primary cutaneous large B-cell lymphoma leg type. They are, as the name indicates, usually located on the leg, but can be located in other parts of the body as well. They are seen most often in elderly women, which is the problem because they do not always tolerate systemic treatment. But this is how such a typical case looks before treatment, and you can see it looks quite aggressive and with multiple nodules on the lower leg. And here you can see what it looks like after 2 cycles of R-CHOP. It has responded very nicely. And this was an elderly lady. She did get through 3 cycles of R-CHOP, could not tolerate anymore, and we irradiated the leg afterwards. And this is what it looked like. These discolorations will gradually subside. So that went actually quite well. But very often the problem is that these patients will not tolerate the systemic treatment. The primary cutaneous T-cell lymphomas are more common. I would just want to mention one entity before the most common one. This one is fairly rare. It's the primary cutaneous CD30 positive lymphoproliferative disorders. And there are 2 of them, the primary cutaneous anaplastic large cell lymphoma and an entity called lymphomatoid papulosis. And here you can see lymphomatoid papulosis is a chronic recurrent self-healing process. It is actually benign. It's not a malignant disease, but in up to 20%, it is associated with other types of lymphomas. Over here, you see the primary cutaneous anaplastic large cell lymphoma. As you can see, it looks very nasty. Usually 80% of them present with solitary or localized nodules like this one. It looks very nasty. It also looks nasty in the microscope, but it's actually a very, very indolent disease. Sometimes they subside spontaneously, but otherwise the treatment is either local excision or local radiation therapy. It is very, very important to realize that this is a very different disease compared with systemic anaplastic large cell lymphoma. The cutaneous ones are always ALK negative. It has no bearing on the prognosis, and please never treat them with aggressive treatment. A colleague of mine actually had a patient referred after intensive chemotherapy for high dose chemotherapy and stem cell transplant, and that's pretty awful when you actually just need a little radiation. And the last one I'll mention is the most common one. It is less common in your part of the world, I believe, mycosis fungoides, and its variants. One of them is the Sézary syndrome with circulating tumor cells in the blood. And just very briefly, this is what they look like. These are the early stages with patches, which gradually become plaques, a bit elevated, going into the tumor stage, and can be very large tumors. It's actually a very nasty disease to have. And this is the erythrodermic situation, which is typically seen in Sézary syndrome, can also be seen in cases without malignant cells in the blood. And they are treated, it's a very, very indolent lymphoma. They're treated with skin-directed therapies for a very, very long part of their spontaneous course. If it gets too deep into the skin, what we do is give them total skin electron beam therapy, as you can see here. It's quite specialized treatment, but it's the most effective treatment for the skin. And here you can see a patient, and you can see how disfiguring it is. And this poor lady had this disease and was, of course, very influenced by it. Here you can see what she looked like 7 years after we gave her total skin electron beam therapy, and so a very satisfactory result. So I just want to mention that in cutaneous T-cell lymphomas, when we cannot, and they're usually managed by dermatologists, especially interested in this disease, and by oncologists because of the role of radiation therapy, but there are a number of new drugs, interesting drugs coming along. And when the disease, which happens very rarely and only in the late stages, if it disseminates to the rest of the body, it's no longer an indolent disease and it needs systemic treatments. And the prognosis is actually pretty poor. But you can see some of the interesting new drugs that are used in this type of patients, including for patients where we cannot control the disease and where it really becomes symptomatic, and non-myeloablative allogeneic stem cell transplants, which we have used in a number of cases. The problem here is to get them into remission in the skin. And it is a very complicated group of diseases, and if you don't see them often, it's difficult. But I'd just like to draw your attention to the ESMO guidelines we made for the diagnosis, treatment, and follow-up of primary cutaneous lymphomas, where these different entities are described and also their treatments. So by this, I'd like to thank you for your attention and send you some greetings from Copenhagen.
Thank you so much, Dr. Specht. You covered the subject extensively, and we are delighted by your participation in this little webinar series of ours. We have some Indian faculty here. They'll probably like to ask their questions.
Yes.
Abhishek.
Good evening, ma'am. A very difficult topic to cover in 1 hour, but you did a great job. I would still like to ask just one question. There's nothing to ask because you said everything. Where do you place surgery in these group of lymphomas? Because where do you place surgical treatments? Because you generally surgery.
Actually, surgical treatment is not really something you use for lymphomas, is it? Except in very rare cases. But if you can remove like a skin, a plastic large lymphoma in the skin, that counts for as good a local treatment as radiation therapy. So it's simply a question of what do you think is best for this particular patient.
Thank you. We have a question from the audience. Do you radiate bulky tonsils due to DLBCL?
If we have a bulky diffuse large B-cell lymphoma, then it's a discussion we're having at the moment, because they will then have a full course chemotherapy. If the patient has 6 cycles of R-CHOP and becomes PET negative after that, we have the discussion whether we should irradiate or not. And I think we tend to not irradiate anymore if we get a complete remission on PET.
The other question from the audience is, if there is an early stage testicular lymphoma localized, do you give radiation?
Yes, we do, because the testes seem to be a sanctuary like the CNS, and there is an increased risk of recurrence locally if the patient is not given radiotherapy. The chemotherapy simply doesn't penetrate the testicles very well.
Right. The other question is, do you see side effects like GI bleeding and radiation gastritis following radiotherapy to gastric malt?
The bleeding issue has always been a point of discussion, and in the old days, surgeons tended to perform total gastrectomies on these patients, which of course left them with a lot of symptoms afterwards. And actually, you see bleeding so rarely. I don't remember having seen any in a very long time. Another point is that these patients will often have had gastric complaints like acid indigestion or something like that for a long time. And then it turns out that they actually have an indolent lymphoma. But when you treat the lymphoma, these patients very often go on having the same dyspeptic symptoms as they had before. And I always warn them that this may be the case, because it seems that this chronic condition has in some way become chronic. And even if you remove the lymphoma cells, they will go on having some indigestion.
The other question is, if there are asymptomatic small maltomas, can they be left alone?
If you have, and you will see that in the guidelines that we made in ESMO, if we have extensive disease, if they're very localized, you can irradiate them, but they will usually recur somewhere else. And if the patient has many elements, small elements on different parts of the body, it becomes unrealistic to irradiate all of them. And it is not a threat to the patient. It's mostly cosmetic. And so usually the patient also realizes this is just not amenable to local therapy, except for steroid cream or something like that. It won't go away. And you can safely leave it and just observe it.
The other question is, which are the parts of the body where you are concerned about the toxicity of radiation and you avoid it?
It's really very much a question of the dose. And in lymphomas, we are so fortunate that we are about half the dose we are using for solid tumors. So it's so much easier, as particularly with modern radiation therapy. The modern techniques that we have enable us to irradiate very, very precisely, and we don't irradiate these large volumes that we did in the past. And that means that even in big abdominal lymphomas that we irradiate, they are surprisingly well able to cope with it, even older patients. And I think that is really important to know also for most of you are hematologists, I guess. And it's important for you to know that radiation therapy has undergone a revolution in the last 20 years. And what you can do today is much, much less toxic than it was in the old days. We have dramatically reduced the volume that we irradiate. We have these highly conformal techniques where we only irradiate exactly what we have defined. And we have also reduced the doses. In the past, we used 40, 45 gray sometimes. But now for patients who have had chemotherapy, we rarely go beyond 30, 36 gray. And for the indolent lymphomas, even lower.
The other question is, what is the treatment for lymphomatoid papulosis?
Lymphomatoid papulosis.
Yes.
That again depends on whether it's localized or not. And for localized lymphomatoid papulosis, we sometimes use local radiotherapy for them to low doses.
Right. Those were the questions from the audience. Any question from the faculty here?
Yeah, so one question. The reason why I asked my first question is I have a patient who as a marked lymphoma of the kidney, and I was going through some of the literature for me. The ASH guidelines suggested nephrectomy.
Oh, yeah.
That is what I could come across. The last
It was
2020
it
paper.
was a more lymphoma in the kidney.
Yeah.
How interesting! I haven't seen that. I thought I had seen it in the whole organs, but you know what? How old was the patient?
He was 65.
You know what I would do? I would give it 4 gray. The kidney tolerates 4 gray very well, and so I'd give it 4 gray. See if that was enough. That would be lovely.
Yeah. So the ASH paper said nephrectomy with rituximab. It's a paper from 2020 which suggests sequencing of treatments in low-grade marginal zone lymphomas. So that is why I asked you the reason whether surgery should be suggested, or because you suggested 4 gray, I suppose that is a better option.
It would be a nice option, but the rituximab idea is not bad at all either, because many of these patients will also be quite well managed. And I use it for patients with recurrence after 24 gray. It's a nice treatment, and it's nice for the patient to keep the kidney, I think.
Dr. Nidhi.
Thank you, ma'am, for that excellent lecture. I wanted to ask, this is in continuation with the radiation therapy. And the side which I want to ask is if there is a primary breast diffuse large B-cell lymphoma in a female patient. So should we consider radiotherapy after giving 4 R-CHOP in that particular patient, or should we avoid radiotherapy and give 6 cycles of R-CHOP?
Well, in that situation, how old is the patient?
The patient must be in 50s, like 52 years old lady.
Yeah. And there was only lymphoma in the breast, not in the axillary lymph nodes. Yeah.
No,
in that case. And how big was it?
It was around 4 centimeter by 3 centimeter size, an isolated lump which was diffuse large B-cell lymphoma.
Isolated, low risk. Well, I would actually give 3 or 4 cycles of R-CHOP and then irradiate the whole breast.
Right. And ma'am, the dose of radiotherapy which you would consider here also is 24 gray or 30 gray?
No,
if the patient is in CR.
This is an aggressive lymphoma. So it was a diffuse large B-cell lymphoma, wasn't it?
Yeah.
In that case, the randomized trial from the British group they randomized the aggressive lymphomas to 30 gray as compared to 40 gray, and 30 gray was just as good. So we use 30 gray now for the aggressive lymphomas.
Thank you. Another question has come up from the audience. In breast DLBCL, does the method of initial surgery, that is mastectomy, versus breast conserving surgery change the radiotherapy administration?
We never do a mastectomy of these patients. It is certainly not necessary. They can do a lumpectomy. They can also just do a biopsy and then treat it as a lymphoma. I don't think it changes the outcome very much, and it's nice for the woman to keep the breast. I would never advise them to do a mastectomy. It depends on the situation in your country. I mean, but that's really in the breast cancer discussion rather than the lymphoma. The lymphomas, I would just hope that they would take a biopsy, and if they found a diffuse large B-cell lymphoma, send them to us and give usual lymphoma treatment.
Dr. Sanyal?
Yeah, Madam, young fit patient with a mantle cell lymphoma localized. Due to the technicality, you can't give radiation. So how do you treat them? The standard mantle cell lymphoma protocol with the R-CHOP, with our high-DAC RSC, or just something else?
But why is it? Because you don't have radiation therapy in the patients?
So the different areas, difficult areas, you can't radiate the area.
Oh, but you can you mention an area I can't irradiate? And you have very good radiation oncologists in India, so they can do as well.
Yeah. So
it's the beauty of the modern radiation therapy. That there's actually no way you can't do radiation. It's a pity because you see, mantle cell lymphomas, if they're treated with systemic treatments, are really incurable. They'll recur. Whereas the radiation therapy, if they are truly localized, it's a curative treatment.
Yeah. Okay.
Thank you. Dr. Abhishek?
I'm just taking the breast discussion forward. Would you give us even CNS prophylaxis to the patient?
No, not we should only have the breast. But I mean, it changes all the time, I think, with what risk factors you think are appropriate for CNS prophylaxis. But the one we're using at the time, at this moment, is not including the breast as a high risk organ. Is it with you? Will you use a CNS prophylaxis with breast involvement?
Breast DLBCL is generally considered to be high risk, ma'am.
Breast? Oh, really? It's not in a, but you know, having been in this area, in this field for a long time, I realized that then you have one series showing a certain number of different areas that are high risk, and then you have another series. It's because it's fairly rare, and for statistical reasons, sometimes you'll find one. I think if you have more than one extranodal site, that's pretty indicative of high risk. But apart from that, at the moment we very much kidney involvement as a high risk, and internal female genitalia. And that was the latest series we looked at.
So Abhishek, we had reviewed this in one of the seminar, and the conclusion was if there's a bilateral breast lymphoma, only they are at higher risk, unilateral not. And as ma'am mentioned, uterus, kidney, adrenal, testis, all those are. But single site breast lymphoma probably don't require.
No.
The largest series is just about 60, 70 cases.
Yeah, you have so many cases, so you're the ones who will be able to actually find out.
Okay, and any other question, please? If there are none, then before I hand over to Dr. Manoj for the official vote of thanks, on my behalf, I thank Dr. Lina Specht for accepting our invitation, being with us. You have been always very kind. You never said no to us. Thank you so much. Manoj.
It's a pleasure. It's a pleasure.
Dr. Lena, thank you so very much. It was a pleasure listening to you. You were so insightful. Thank you. You have a lovely day ahead. Thanks is also due to the gentleman who is smiling, but there is a lot of hard work behind this smile, a lot of coordination, a lesson in management for all of us. Thank you, Professor Dr. M.B. Agrawal, sir. Thank you for bringing a lot of smiles, a lot of insights. Our chief guest, Dr. Hemant Malhotra, for those pearls of wisdom, Dr. Stephen and Dr. Luca for those wonderful insights as well. Experts from India, Dr. Sanyal, Dr. Sandeep, Dr. Sweta, Dr. Amit Khurana, Dr. Mahadev Swami, Dr. Nidhi Jain, Dr. Ashwarya Raj, Dr. Abhishek Kakru, Dr. Gunjan Prasad, and Dr. Isha Kaul. Thank you for making it so enriching. And today, sir, once again, a full house. There are many countries, but 14 are prominent. So I must thank the delegate from these 14 countries and others: India, Malaysia, Sri Lanka, Bangladesh, Myanmar, Pakistan, Australia, Indonesia, UK, USA, Belgium, Philippines, Cambodia, and Iraq. Thank you. Good day and good night to wherever you are.
Good night. Thank you very much.
Thank you, Dr. Manoj. Bye-bye. Bye-bye.